Hi, good evening. I'm just waiting for 1 minute more. And Dr. Rohan, can we see you? Can you please switch on your webcam?
Is it good?
Yes, perfect. So I'm just waiting for more people to join in because we already have 142. It is tickling like in seconds, multiple people are adding. So I'm
Yes.
just waiting for a few, 1 minute more and then we'll
All right.
start.
All right.
Just bear with me. I'm just sharing the new link with everyone. So, Dr. Rohan, I will also share the link with you. You can, forward that link to your friends also,
Yes.
because I think there was some issue like yesterday also we had the same issue. I had dropped an email to the company, but I think they are not able to respond back because of this COVID issue, because of it maybe closed. And still sharing a link. Yes, you forward this link to your friends and they can connect to us. So we have now 190. So let me update the number. Okay. Link. Dr. Shobhadandan ma'am wants to join and she's having a little bit of issue. So refresh browser. So now we are 232. 240. So yes, it is 539. Dr. Rohan, where this music is getting played? Is it your music system?
Playing. It is. You can't hear it well.
I could hear you.
You
I
can
could.
hear the music. I'm just putting it up to increase the mojo. See, it's like a virtual party when people are meeting. We get a very few chances to meet globally like this with multiple people
Yes,
in the same room.
yes. I
And
will keep
yeah,
introducing you, Rohan. We have many international friends today. From Israel, we have from Jordan, from Egypt, we have from Saudi Arab, Sudan,
oh,
Hong Kong, China, Malaysia, Singapore, and from Europe, also, from Italy also, and UK. Then we have from Afghanistan, Pakistan, and recognize many of faces because we are always in touch. So uh, no doubt, maximum number is from India. So I think we have till now about 21 countries are participating. The webinar 21.
wow,
Yeah,
that's a good number.
yeah. From Sri Lanka, yes, we have few members from even Nepal.
Yes.
Yesterday, few of the students registered from Nepal also. So we have few students from Nepal. And UAE, yes, we have from Abu Dhabi as well as from Dubai.
Wow. Wow.
Yeah. So I think now we can start. We have quite good number now, 310.
Excellent.
And we cannot, I think, make our friends wait more.
Perfect.
Uh,
Perfect.
so, friends, very good evening to all of you. Can you all hear me? Am I audible? Yes, Dr. Rania, I know you well. You are from Egypt. Welcome here in this webinar. Lina from Colombia, yes. Lina and Sandra, we have from Colombia. And Dr. Moin is from Libya.
Wow.
And Marin Donat is from Italy. From India, Dr. Masmi, Dr. Amina, yes, we have. Constanza, she's from Ecuador. She's also with us. She always attend our lectures. Wow, what a great number we have today. Wonderful. So, friends, let me introduce our very own speaker for the today's webinar, Dr. Rohan Bhatt. I met him a few years back in one of the exhibitions in Delhi. I was just moving here and there, and suddenly someone tapped on my back, and then when I turned, I saw Rohan there. And from there, we are friends like anything. We are the best buddies. So he's a younger brother to me, and Rohan has actually completed his graduation from Bharti Vidyapeeth, Pune. Am I right, Rohan?
Yes.
And you
Yes.
have done your post graduation, I think, from Shah
Vadodara.
Dental College, Vadodara. And now you have started post PhD also. I think you are doing
Yes.
PhD.
Yes. Yes.
And the wonderful thing about Rohan is, apart from dentist, he is a corporate. He has started his own company, that is Signature Crown, and he has patented rather his own design of Zirconia crowns. And he's the founder and architect of this company. And I'm very happy to say and tell you the fact about him, another fact about him, although there are so many facts about him. He is running a practice in, he started from Ahmedabad, which is one of the best pediatric dental practice in India. He got award in 2015, if I'm not wrong, Rohan, for being the best clinic in India. And now he is running 4 centers in total in Mumbai as well as in Ahmedabad. And his clinic, one clinic is around 3,500 square meters. I always seen the pictures only. I could not visit his place, but definitely when we are going to a national congress in last of this year, hopefully it happens, and we will definitely going to visit his place. And he is now currently professor and head of Department of Pediatric Dentistry in Karnavati Dental College, Gandhinagar, Gujarat. And he has conducted, which I know, roughly 40 to 50 workshops, and he has trained more than 2,000 dentists in various techniques in pediatric dentistry, in preventive dentistry, as well as in restorative dentistry. Uh, Rohan, I am very happy to see you here and teaching our people about the field of zirconia crowns, especially in pediatric dentistry, and that too in complex cases. So, welcome, Dr. Rohan. And I
Thank you, sir.
welcome to all my friends, all our attendees in this webinar. We always feel great when you get together in such a number. And basic purpose is like the distribution of knowledge and conducting these webinars. That makes sense, actually. Thank you so much, all, for being here, for supporting us. And now over to you, Rohan. Dr. Siva sir wants to say hi to me
Hi,
and
Rob.
to you, Rohan.
Hi,
And
Dr.
let's
Shiva.
start with the presentation. Over to you,
Absolutely.
Rohan. I will be with
Thank
you
you.
to follow up your journey, and
Thank
my
you.
webcam will be off, my microphone will be off. But wherever we will feel any difficulty, I will switch in, and
Thank you,
I
sir.
will keep communicating with our attendees for all the questions and all that. And wish you
Sure,
all the
sir.
best. Please,
Thank you. Thank you,
over
sir.
to you, Rohan.
Before you go off, one thing I can tell you is you got an amazing set of memory. You still remember our first meeting, and it was
Oh,
a
yeah.
really random one. And I wanted to talk to you, and I like how to do it. And we just started talking, and we hit off so well. And I think it was some 5 7 years ago, and till then we just constantly with each other. You helped me out a lot on this, so thank you so much, sir, for
Most
giving
definitely.
me the opportunity. And I wish I would have met you before, but time say bye. But we met finally, and today I like to do the justice to the opportunity which is given. So thank you so much having me. Thank you so much, guys, from coming from almost 20 25 countries and attending this session. It's going to be, I thought of keeping it basic as well as some of the advanced cases I put it on. I'm not a guy who talks a lot of theory about it, so it's going to be more of practical day-to-day learning and anything. If you have any question, you can shoot right away in the chat box. And if you have anything, sir, you can just interrupt me anytime to put it on pertaining to the topic. Someone is not, someone got confused, someone will ask more. Don't wait until the end. We can just take it at that point of time as well, because there's just cases I'm going to show, and to understand that each case is what difficulty I face and somehow I managed to overcome. So that's the whole idea of practical DIY of zirconia crown and a practice which I do it. So, sir, shall I begin?
Yes, please, please.
Yeah. So can we have the slides, please?
You will go to slides first.
Yeah. And start presentation.
Yes, wonderful.
Perfect. Thank you. So I think by the way, you must have seen when I put it on as an introduction that my workshop name were Narcos, and someone from the Colombia has joined. So the person can really appreciate what I'm saying here is I'm a big fan of Narcos TV series, and I'm a fan of TV series otherwise. That's what I watch normally. And Narcos was a name inspired to, in a full form, is New Age Reform Clinical Operating Science. That's the full form of Narcos, of the first letter of each word. And out of my workshops, we made it as a season 1, 2, 3, because I speak on various topics. So season 3 and 4 is regarding steel and zirconia crowns or restorations, which you say in particular any country which you are from. So that's why my workshop name are Narcos, and we try to create our creatives. Looks like a little bit of Pablo Escobar, because I've got also seeing similar gray hair kind of thing. That's how it is. Now, sir has already introduced me, but that's what we do. I have a private practice, and that's my major area. And plus, I am also one of the director with my university, and I do teach to the university a couple of days in a week. And I do conduct private workshops for the same. So, coming to the main thing, what we are here for, what I'm going to cover today is which I've always seen a simplified word, what to look for. So people who are attending, they can look for that why we are using a preform crown system, why we're not going behind the lab meds. The SSCs, how we evolved from SSC. Now SSC and came to zirconia in last 5 to 10 years, which has swiped the whole market away. So why zirconia? Where to use it, how to use it, this is what we're going to cover today. Plus, what are the preparation techniques which we're going to see it for posteriors, anteriors as well. Protocol, what goes first, because when you're doing a single single tooth crown, it's very easy, right? For any restoration we do it. But when it comes complex cases like multiple teeth together, upper lower together, and especially when you are working under anesthesia, that plays a significant role. Then comes the placement techniques, right? It makes a big difference what crown goes first, what goes later, and all stuff. And then luting protocol, how an adhesive will vary from your anterior to posterior, and different restoration, and how I do it, and which I found out to be easier and long lasting in my practice. So that's what the whole idea is all about. So this is what my whole what you call umbrella of my presentation. You can have an idea about it, and that's how I'm going to go further. So before I go into it, and before I get into it, I all know, and I always do a little prep talk before getting into it, because straightforward zirconia is like everyone knows where it is required and all. But before, right now during COVID times, and I think 25 countries of each participant of each country will agree with me that this is the toughest time, toughest time mankind can see it. This is a time we when we sit back home, for some of the country got locked down before. This is our, I think, day 50 or 52 in India. So we are having a complete lockdown, and a couple of cities are totally going to like totally shut down, because of they have divided in red zone, green zone, and amber zone, depending on the COVID patients as the spread according to the areas. But every country, every individual, and particularly I'm addressing dentists, every dentist is right now is suffering, because they are sitting back home, they are not able to work. There's so many problems. I attended a fantastic webinar day before, how to start your practice and how to maintain the disinfection. So those are the protocols to be followed, and it is really taxing. We started our practice a couple of days back, and it just took us 3 to 4 days for our staff to even come to the point that they can take each patient and maintain the checklist protocol of maintaining the hygiene and disinfection the whole area, because the place is a little bigger to maintain the thing. It gets really tougher. So this is the time I can tell you is we all have to remember that what is our legacy, right? What you want to live it on, because the way we are living right now, it's going to get finished. Like we see a lot of people dying, so we need to remember what we are here for and what is our legacy. And our legacy is to produce amazing quality practice. Our legacy is to do best each day and deal with each day how it comes, because what I've learned in last 50-55 days in this quarantine time is three factors: decide, do, and do not quit. First, you make a decision that I'm going to do this thing, then you do it that particular moment, that day, that hour, and don't quit until it happens. That is kind of an attitude which I'm trying to develop, and I'm just sharing with you guys. This is something is exactly important, because that will only will make you keep you going on a longer run. If you just sit back home, keep watching TV, reading those negative news about how many people are dying, this many people are getting affected, like it looks like a sensex of stock market, the number is going higher, number is going down, and then end of the day we all get frustrated. But guys, if you just see behind, I read it somewhere in the newspaper that before COVID, every day more than this, people were dying due to road accidents or some of the countries with malnourishment or etc. Some of the reasons. So people were dying with the natural cause, and I always believe in it's taking a little risk of our life and fight it back. A little risk. I'm not saying risk of the doing practice in a very bad way. I'm taking risk of the life means testing it, the blood, and encountering it at the right moment. So if you take an example, I read it somewhere like 30,000 people die every day in any sort of car accident in this world, right? So, but still we don't stop driving, right? Each day to go to work, to drop our kids, to school or to do something, we have to go on road and we have to drive. So we are not afraid of driving. We know that it's so fatal that car accidents are worst in the market. Motorbike accidents are the worst to kill people, but we still go out and practice. And do it. The same way, we know this COVID is so dangerous, but we have to push ourselves. As I said, decide, do, and don't quit. Learn all these things and get back together. And on that note, I'm going to start the session that don't quit and learn something new. And learn something new is something we're going to see about the Zirconia crown things. So the first part of it today is why preform crown system, because there's so many people when I do a workshop and by end of it they say, okay, but doc, what is it? I have a good guy who manufactures a monolith zirconia crown in my practice, so I make a prep, I do my prep, I make an impression, and that guy makes me a lab prepared crown. So what is the difference? Why do I need to get into a preform crown system? What is the need of it? So first, before getting into SSC or zirconia, I can tell you is what and why there is a preform crown system and how it differs. Take an example that a 3 or 4-year-old is in your practice and it needs a mutilated crown. You need some pulp therapy, or if there is a class 2, a complex restoration you need to provide, and that's where you put your hand over. Because I'm not going in detail of the indication or core indication of crown and extracoronal restoration, I would assume that all of us know, because all of us have done some or other kind of strip, zirconia or SS in our practice. So not going in this really basic detail, but taken a scenario that a 3 or 4-year-old is in your practice and the mutilated one or a pulp therapy treated one, or let's say a wall broken kind of a tooth case, and you need to restore it well, and that's where you decided to go for any extra coronal restoration. Now, what are the biggest challenges we follow is, imagine we are not using a preform crown system. So first you need to do a perfect crown prep for that particular tooth. Imagine in a child you do a perfect crown prep, because if there is an undercut or there is something, it's going to be a very crazy time because your lab prepared crown will not fit. So doing a first one crown prep is very important. Then every crown system in deciduous dentition which is being used, or let's say in a transient dentition, because we also treat a lot of young permanent molars as well. So in say transient dentition, or let's say in a mixed dentition, what we use is going to go subgingival, because it is going to change the position of the tooth as the tooth erupts. It may go further, it may go back because of the different shift happening and this and that. And that time, if your crown position it is at equigingival level, or let's say at supragingival level, then it's going to create a good pocket to the gingival area. So we cannot allow it to happen. So every crown system what we use in this transient or a mixed dentition phase, it has to be subgingival. So imagine to do subgingival restoration or subgingival crown. So when I say crown, I mean I would also, when I say restoration, I refer to crown. That's not the way we speak here by. So you have to do a crown and which goes subgingival. Then imagine, guys, how to make a subgingival impression. You have to do some or other kind of a cot packing or some or other kind of margin opening of that particular area. You can do chemically, place some gels or place some instrument. Now they have devised something, or you can go for a typical cot packing, improve in order to open the margin so that your impression material can go in. So now the second complicated step after doing a fantastic crown prep is putting up a cord or something, which is extremely tough in a 3 or 4 or 2.5-year-old or 5-year-old child. Third toughest thing, if at all you could manage to pull out this thing very well, you have to make an impression. Now, how many of you agree? You can give me a heads up here in the chat room, and that's how I can imagine that I'm with someone. I'm not just staring at screen and talking. Is agree with me that making the impression is one of the worst thing or a worst procedure we are doing it in pediatric dentistry. I hate making impression. It's like you're putting a lump of the thing in any child's mouth and child is about to puke. It's the worst thing, right? Because it's very intolerable for a little mouth to go a lump of any soft impression material and goes above the palate, or when it is down, it is really bad. So I would say 5 out of 10 kids normally puke during their first experience of impression, although they are under nitrous or not. I would always say. So making an impression, the third step, is extremely difficult. If at all you manage to pull out that step very well, after you made an impression, it has to go for pouring. Once you pour the cast, it has to be an extremely good cast. If your reproducibility of that cast is not that good, then what's going to happen? You can't repeat the impression because somehow you made an impression. So what's going to happen is that problem you have to go through again. So if you obtain an amazing cast, imagine. Now that cast has to go to a lab guy who has a CAD/CAM machine to make a zirconia crown over it. So now, guys, coming around a word called turnaround time. It's a corporate word called turnaround time. Means someone would pick up the cast from your practice, and that cast will go back to the go back to the laboratory where they scan it, design according to the specific the tooth which you've given. The particular tooth which is required. They're going to do milling of it, scanning, milling, polishing, finishing, and then that guy, everything happens, finishes very well. They're going to pick up and give it to you. I can tell you guys, best of the lab you send, except your own lab, will also take minimum 1 to 2 days. And as everyone read long ago in 1975 to 80 in the textbook of McDonald, that the space loss happens in first 24 hours. So if at all you've done a beautiful crown prep, made a best of the impression, which is called subgingival as well, your lab guy has prepared amazing crown, your turnaround time is, let's say, 48 hours, and 48 hours later, whatever the crown you get will not fit on that particular tooth. I can guarantee you. In particularly 8 out of 10 cases, it's so extremely difficult so that it may fit. And then end of the day, what we're going to do, we're going to either fidget with the crown, fidget with the tooth, and then try to overcome the mistake what we have made. So, and why to do this majorly? Because that is the reason we don't do a lab prepare crown for, maybe let's say in the metal ones, maybe let's say in the zirconia as well. Even in a metal lab prepare, if they don't have a good CAD/CAM machine, the steel crown what we are getting is a 0.1, 0.2 mm thickness crown. So you're not going to achieve that thin crowns, and then you're going to keep putting up those bulky crowns, which is a poor margins, and then plaque adhesion, and then biofilm. All these things create a big trouble on a long run. So guys, I can tell you, is the worst thing what we can do to our patient is going towards the lab prepared crowns. That is why the preformed crown system invented almost from now, let's say 70 years ago in 1950. Humphrey introduced the first steel crown to the market, and they say that is what the boom of the preformed crown era was invented. So, and by now there is no replacement of preformed crown system as found yet. So everything, an extracorneal restoration in pediatric dentistry, whichever system you follow, has to be preformed crown system. On that note, I'm moving ahead with the basic. What we used to use was the stainless steel crown, and before the Zirconia came into practice because Zirconia brought a lot of aesthetic value to our practice. So till that time, those steel crowns was available. There was like the frontiers and pioneer of them was the 3M Unitech crowns. Now it's called 3M ESPE. In globally, it has been selling. So they said it's an interior crown. They were a posterior for deciduous, and the permanent was in a separate kit. For interiors, then people found out to make a window. They used to laminate it, and somehow they used to create a beautiful white crowns and an aesthetic restoration. So posterior, they also tried with the front facing ones. So the buccal margins were like white in color so that it looks good to mask the steel or a gray tooth phenomena. So this is what a gold standard. I'm not saying that zirconia will replace the stainless steel crown. It was there, it will there because it is still one of the most economical restoration a child can have. Okay, the most. Zirconia also does come to a cost. If you compare in global scenarios, zirconia would cost minimum around in India is like $10 to $12, and if you go by steel crown will cost in India roughly not more than let's say $3 to $3.5. So it's like 4x price, which is more of zirconia. So the price is one of the factor for any parent to pick up any treatment depends on the economical zone of the area we live in. So we can't just quit practicing. SS is there, SS will be there as a vital option, but zirconia is a good alternative of a age old SS practice and kind of an upgradation of your SS practice, because you can give both the offering to your patient. This is what we do in our practice. So when we do our primary consultation, just off tip I'm giving you that when we do our primary consultation, my counselor gives them both the tip. Okay, we don't fascinate them, we tell them this looks aesthetically pleasant, less plaque adherence. We've been doing steel crowns in multiple years. This is also not bad. Both of them are equally good in terms of longevity. You're just paying extra little bit for the aesthetics and more of the little hygiene, but it's like 70-80% is aesthetics and 20-30% is that angle of hygiene. So now these are the cost difference between plan A and plan B, because these are the multiple teeth involved and these are the basic port for the treatment. So plan A is with the steel crown, cost you this. Plan B is the zirconia, cost you this, and you go home, decide what you want to spend behind your child, what your budget is regarding this treatment, and it's up to the patient. We put the ball in their court and they go home. They discuss. If they feel they can pull up a little bit more socks and run towards more aesthetic or more advanced restorative material, and then they'll come to their practice and they'll tell you, doc, I want to go for zirconia, you do your zirconia. And if they say, no, I can't afford that much, or I want to, I just want to save money, or somehow I'm not convinced, I don't want to go for that, I want to go for the conventional one, so you can go for steel crown. So still steel crown is there and steel crown will be there in the practice and is not going to go change. So we be very neutral in our practice in order to promote that. Now, as I said, what are the advantage of SSC and what were the shortcomings? So the biggest advantage, as I know in my practice, was in the area where I practice and the city and the country is India. So India is economically balanced country. I would say it's not that higher like American country or some of the European countries, or it's you cannot compare the countries like that. But in the economical forum, if we see it, it comes in a middle way. So here we see a lot of population who can spend well, so they go for the zirconia, and the people who don't want to spend that much, they go for steel. So the biggest advantage of steel crown is the economics. It is cheaper and it is by far the cheaper one, so you can't just take it away from that. The second, the biggest shortcoming of steel crown is the aesthetics. It's silver in color, and no one today wants to go for a silver restoration, because every kid, let's say by age 2, 3, 4, 5, 10, 7, whatever, you see in any country, the parents are so much attached to kids nowadays. They get their photo shoot done, they make fancy albums, they put it on social media, Instagram and Facebook. They celebrate their birthdays, they celebrate all the festival. Within a year, once or twice, they have a fantastic photo shoot. Even their camera phone, have 20, 20, 15, whatever megapixels of camera. So when they shoot a kid, they want to have a good pearly smile. So the SST is still good for posteriors, but anteriors needs a good replacement of this thing. Middle of the time, there was a strip crown in the market. It is still available. Many countries use quite widely. I used to use a lot of 3M strip crown in my practice. I used to love it because open face stainless steel crown was the challenge to do it. You need to prep the steel crown, put it on, and then veneer it. And it was a very tough procedure. So the strip crowns was a good alternative. But what I used to find as a trouble of the strip crown was, let me go a little ahead. Okay, that's what it is. So as I said, the posteriors still good. Anteriors were the biggest shortcoming of the stainless steel crown. So strip crown came into picture, and strip crown, yes, it was a celluloid strip. It's like your jello molds, you prep the tooth a little bit in order to create the space, because this crowns are really thin. So you just have to slide it over. Once you get the right fit of the crown, you need to cut from the neck in order to check the crown, create some escape holes in the crown, because you're going to fill up composite into it. That's an additional step. Then if at all it goes to the subgingival level of the crown, then the clavicular area must have started bleeding, so you need to arrest the bleeding, because these crowns are the adhesive crowns, because you use adhesive to lute or to stick this crown over a tooth, right? That's what the right word is, to stick this crown over a tooth. So you need to put etch in. If you're using 5th generation, it's going to etch and bond. If you're using a 7th generation, I would still suggest to go for a little etch for the enamel and then go for the bonding. So there are 2 additional steps. Control the bleeding, pack your composite into that celluloid strip crown, slide it over, remain stable, cure it, then take a small blade or a sharp instrument, create a small slit over a crown or cut it over and then peel it off, and your voila, beautiful crown is there. Such a technique sensitive what do you call system. It's a quite technique sensitive, number one. Number two is it is all depends, the strength and longevity depends on an adhesive. That means your bonding, because the composite lump which is in shape of a tooth stick over your whatever the left structure of the tooth. So the biggest challenge of strip crown, it fails. And guys, mind it, I am telling you this sentence, and which is out of my years of practice in communication with parents and staying with them, is once you give an aesthetic restoration to a crown, every parent will demand it, that aesthetic value back until the tooth falls off. Once you give an aesthetically pleasant restoration to any child, the parent will never forget. Okay, never forget. Okay, if you give an beautiful anterior 5161, we follow FDI here, so my notation will be a lot of FDI. So people who follow universal may find some confusing, but I don't know universal much, so I would rather stay with Palmer or FDI. So 5161 is the central lateral incisors or central incisors, which you give a good aesthetically pleasant restoration. What's going to happen? It may fracture. Child is eating something from the front, child has a fall, had a fight with another child, or something happened, a football kicks in, and the restoration broke. They will keep coming to you until the tooth is going to fall off, because now they don't like. So for that particular first 1 or 2 years, the child was living with a black teeth, and that time there was no issue. Once child got a trouble, they came to you. Now you've restored a fantastically pearly looking smile. They will want that smile back. If it gets broken, you keep redoing it. So what's going to happen, used to happen in our practices, we were doing more of the repair work of our old broken strip crown, rather than every day we were doing lesser new strip crown. So one day I decided this is not happening, guys. And this was still, parents were demanding, what is posteriors alternative? We don't want the way you've done a front white, we want a white back, but we had no answer. And that's where they came into the picture of this zirconia crowns. So zirconia crowns came into the practice, and that was a right need, that this 2020 era, every parent wants child to have a beautiful looking white tooth. Maybe it's posterior, maybe it's an anterior, and particularly interior is the prime most important of any child's smile, because they pay mammoth money For a photo shoot, they pay mammoth money. For to buy clothes, they pay mammoth money. For child's birthday or any other event celebration, and then ultimately, if it is not looking good, aesthetically pleasant for them, it's a big memory for a lifetime. And if they are not able to get that big memory of a lifetime, they'll never be happy. So the need of an hour is aesthetic dentistry, and aesthetic dentistry involves a lot of with zirconia now, and that's where zirconia is most in thing or most talk of the town in pediatric dentistry right now. So that's a major reason why zirconia. There are other materials that are in process now. They're like there is another crown system called Edelweiss, is more of kind of an composite related crowns. There are different crown system available, but by far, if you say aesthetically pleasant, easy to manage, these are the material properties. The basic one I'm going to talk. I'm not going in detail, as I mentioned before. I'm not a fan of much of the theory. According to me, I'm kind of an educator who strongly believe that theory is for the books. It is given in a book. Someone wants to learn theory, they can go to book. This kind of webinars now, or a practical my workshop where I conduct across the world, is to get to know people, get to know the person who's talking, how he's done it, and more of the DIY of that particular guy to get connect with. So I'm going to be more on the practical side. But a major advantage of zirconia is fracture resistant. A good quality zirconia, if you use a 3M lava, I particularly endorse, is as minimum 11 to 1500 megapascal of the shear bond strength. So the high fracture resistance, it is extremely color stable. Like a lot of people have researched zirconia crown, that they've done multiple autoclaving cycles when they want to decontaminate the crown, because if you have used as a trine, it doesn't make much of the difference, and if it is lying like this in your shelf, it's not going to change it. Wear resistance, now this is very interesting topic to discuss. A lot of people thinks that zirconia is very harsh on a tooth, but we've done multiple of it. I'm going to show you some 3 year 5 year follow-up cases if I have enough time to go about today. Is it doesn't have that significant wear, but the wear resistance is fairly good enough. As I'm not going to compare with SS crown, but maybe with the lithium disilicate you can compare, and the fractional behavior. So it doesn't fracture that properly if it is adapted well. So these are the core components. That's where zirconia was our material of choice in order for the aesthetically looking or a pleasant looking crown. Now, why zirconia? Simple logic, easy to place, easy to store. These are the crown which is so good color stable and doesn't fracture that easily. And I particularly look at, because every practitioner should look at their practice as a good business. And the way good business is, you need to understand your supply chain management. You need to understand the way you're going to manage your stock and indents. You need to understand your manpower and how you're paying about it. You need to understand the schedule per hour of earning and etc. So we are very keen on it, and we keep working on it. And one thing which I've learned is we always stock up and buy things in a good key, which is practically no expiry date. And in pediatric dentistry, guys, it's only two things what I found till now. As practically no expiry date is your crowns, steel crowns, and your zirconia crowns. So practically this crown has no expiry date. So you can buy it on. Some people ask me some of the least size to be used. Should I buy them? I said buy them. One fine day you'll get a patient and you are going to use about it. It's not going to get over soon. It's going to get expire. So the best advantage is easy to be stored. It's like a very delicate box. You can just put it somewhere and it has no expiry date. So you can invest anytime you want, and it's going to stay with you until the crown gets over, and then you can order a refill about it. So one of the biggest advantages is this one's. Another advantage, no additional armamentarium. So if I will compare it with, let's say, an SS crown, you need your pliers, you need your set of good scissors, and I'm a really good fan of scissors. So I would highly recommend, if it or someone is still doing it, go for a 3M scissor. It's by far the best scissors. You need to buy those pliers, those scissors. Then comes your band pusher and then band seater, so that at least you can check it, the crown thing. Then you need a crown remover and etc. Then you need those trimming burrs in order to trim the crowns, because depending on the ethnicity of the population, the crown height and everything gets changed. So that's an armamentarium you have to keep. But first you have to buy it, and second you have to keep sterilize it and disinfect it each patient, and or you have to have a multiple set that you have to invest in. So here in Zirconia, there is nothing practically you are doing anything with the crown. So there is no additional armamentarium required. In even strip crowns, you need those composite resins, etchant, a very good quality bending agents. You need an extremely good scissor to cut the crown, and etc. So here, no additional armamentarium. Second major point is no other manipulation. Even in your strip crown or SS crown, you're reducing the height. The moment you reduce the height, they are pre-formed crowns. So means pre-contoured, pre-trimmed, etc. So when you see a pre-trimmed, pre-crimped, pre-contoured crowns, if you touch the crown anywhere, this property goes away. So you need to re-trim. I mean, once you trim them, you need to re-crimp, re-contour in order to place it back. So there is a good amount of time you are spending behind manipulating that crown in order to fit on a tooth. In Zirconia, nothing. You do not need to touch your Zirconia crown. You just need to do it the way I'm going to show you in the further slides. No additional luting cement. Like there is nothing you are extra investing apart from the kit. It's your own luting cement which you have it. Like if you have a GIC, it's good enough. If you have pure resin, which I would recommend in some of the cases, in the further discussion I will show you where it is being used, is good enough. No fancy burr system. You don't have to buy some weird burrs with weird taper size and weird the particle size of the diamond point. You don't have to buy those diamond points. It's your routine burrs, which are burr to be used. I'm going to show you later. But routine burrs are way more than enough to be used. So do not worry over it. Okay. The next thing comes is why preform kit. So as I mentioned, the advantages of Zirconia crown over SS and a technical advantage of the same comes the kit. So many people ask that it is an investment for us to start a kit. But guys, I can tell you it's my fundament over any business is whatever you invest, you get in return. You just sit back home, invest a little and pray to the God that God give me the more money. I'm saying pray to God means keeping the faith, but this faith will not help you. Keeping the faith is the good thing to succeed in life, but without investing, you can't do much. So the best thing to do in your practice, guys, I can give you one tip which I learned very early from my father is to invest at the right time, at the right place. Do not hesitate. Invest back into your own practice, the best investment. Because one fine day, a couple of years ago, when I started making little money, and when I asked my father, where should I invest this money? Because I've started making profit. He said, why want to trust some other people, some other company? The best way you can invest is invest back into your practice and make more money. Rather than you invest in someone else's business and depending on him, how he's going to perform, and that money is going to come to you as a return, it's not relevant. You should invest back. So the first thing you require is a kit to be purchased, and it is going to come to a cost of it. As I mentioned before, every crown, an average cost is between $10 to $12. So you can imagine a kit would cost you, depends on that. Like your 50 is an usual crown size. If you find it all, 15 to $12 is something $400 or $500 you're investing for the first time. First time to buy the kit, and then you're going to start. But kit is extremely important. Reason being is these are all pre-formed crown system, and every pre-formed crown system, how it works, you're going to see it later, but depends on the width of the tooth, you're going to select a particular crown size. Now I can tell you guys, a lot of people call me and ask, doc, tell me, you do so many crowns in India, which are the most used crown size? You tell me, is it 345 number? Is it 5 number? Is it 4 number? So what I'm going to do is I'm going to buy those particular commonly used size, and I'm going to keep it in my armament, and I'm going to use it. And if it doesn't fit, I'm going to order it. Now your patient is your doorstep. Now your patient is at your doorstep. You've done your prep. According to you, 4. It came out to be 3. Now you don't have 3. You send the patient off. The 3 number crown comes to your doorstep, and then you call the patient back again. It's going to be collapse. The crown will not fit because the space loss has already happened to weight. Now imagine you've not prepped, and you're waiting for the crown. So you did your pulp pack today, and then you're calling the patient next for the Zirconia crown once you order them. So you may have to inject LA again and do all these things. So the best thing is to do it all single visit. That's what we've learned in our postgrad life, in our learnings of fellowships and masters when we've done. Is anything and everything we do in pediatric dentistry is the quadrant dentistry. We treat each quadrant all together and in the same time when you give LA, finish the whole job. So the whole idea is to save time, whole idea is to save child from the misery, whole idea is to the time and energy you invest making the child cooperative into a dental practice so that he can or her, she can sit and go through the whole procedure. If you give a break, the whole behavior management strategy is going to start from scratch one. You're spending so much of time. In pediatric dentistry, guys, the best thing to learn, another practical tip is a time and money ratio. A lot of people forget that. They spend like 30 minutes behind a child management, and eventually we pull out one small restoration. It may sound like an emotional win-win for you because you could manage to perform some procedure, agreed, but at the financial level it is too mean, because if you're spending 45 minutes behind one restoration, you have 8 working hours a day, you can't pull up your socks in order to excel further in life. So we have to make that scenario change, and time money ratio is something equally important to understand in order to succeed. So if you want to succeed, guys, the best thing to understand is time money ratio. If you're spending that much time together, when the child get cooperative, you might as well pull up more of the treatment at that particular day in order to balance your time money ratio. So your kit saves that. Kit means it's ready with you. If your patient is ready, you did your pulse therapy, you did your whatever excavation, now it's the time for crown. You take out your kit, select the right size, fix it, guys. Bang on. It's done. And and you made money that particular day, that particular hour when you worked. You've not delayed the treatment. You not put the patient in dilemma that once they go back home and think about it. Do I really need a crown after my pulse therapy because my pain is eradicated? Although my doctor has told me that if you don't go for the crown, it may fracture or you won't be able to chew well. But let's see if it is going well. We will not go for the crown, save some money, and let's see if he's having a trouble. Then child will complain back to me, and then we'll go to the dentist again and get the crown fixed. But guys, I can tell you, child are so beautiful creature that they will never complain they're not able to eat well. Okay, they don't realize that their nervous system is not developed in a way to tell parents that daddy, my one of the tooth has low contact with the opposite tooth and I'm not able to chew. It's not going to happen that easily. So, and you may lose out on patients. So according to me, my principle of working is you do it all, you do it now. You pick up the case, you finish the case. Although maybe sometimes the time constraint happens, sometimes the child's cooperative capacity is at all, and you make a decision of doing a multiple visit treatment, that's okay. But try to do it as much as you can in a single visit, and that is what key to success in now, this COVID era, when we are going to take utmost precaution. Imagine a child walks in, you fumigated the area, you are wearing PPE. PPE is also does come to a cost. You're wearing those N95 masks, another mask on the top, your loops, your shield, your head caps, etc. You're in the same thing your assistants are wearing. You've removed all these disposables to treat one restoration. Not happening. So better you do the quadrant dentistry altogether and make your expenditure behind those PPE and extra disinfection techniques and the stuff what you invest behind all this to follow this protocol makes worthwhile. So that's where also does make sense now to do a single visit thing, and that's why you need a kit. You just can't rely on buying some common sizes, sit back home and pray to God that this size patient will come to you. Guys, take an example. I always give this example that a guy who is a shoe merchant, okay, he is owner of a let's say an Aldo or let's say Gucci or something shoe company, okay, or Valentino or whatever, and that guy only buy, let's say the most common size in female is like 4 or 5 and male is like let's say 7, 8, 9. He only buy 5 good shoes of this particular size. He's opened a fantastic shop. He's sitting there. He's praying to God that, okay, send me some more clients. Client comes to his doorstep. He says, okay, show me this shoe. And he said, what's the shoe size? He says, size 9. Imagine what's going to happen. He's a red hot client, but he doesn't have the size. Some client, maybe some lady walking, needs stilettos, black color, fantastic, they have it, but it's not available in size 4 because he's just got size 5 and 6 available. So that's going to happen to you, and this is going to happen to you because we as a dentist should understand, never believe on luck, always believe in the system which we work in. You can't get lucky that easily that whatever the particular size only you have, that patient will come to you. That is why I always tell you to invest in your practice and buy the whole kit. Now, what are the options available in the market? There are multiple options available in each country, multiple brands available, starting to an end. There are, like, I think I'm not wrong, but there are, when I saw, there are 8 or 9 good brands which is available globally. They supply and they do it. All of the brands are fantastic. They all have their CE certification and everything is good. Only thing to select is the way you practice and which fits your, the working pattern or the way you feel it. Like, some of the companies have little different designs, and some of the countries those designs fit very well. So you need to just look into that and you need to do it. But how to select the company? So what are the inert features of each crown, which I look into it. So when we do have our own company of crowns, so but before that we were using multiple different companies. So how did I select my companies at that point of time, and what are the inner features of each crown which should have once you are buying any kit of any company's? First feature is it should be minimum of the sizing. Okay, there are companies which has got from some 7 at regular sizes and 7 at some narrow sizes, so they're like 14, 16 different sizes. Now imagine, we need it for interiors, like for central, lateral canine, and the premolars, etc. So 5 each side we need it, and imagine 14 different sizes of each tooth. So 14 into 5 each size. Crazy. It's going to be crazy. So 20 into 14 is going to be roughly, let's say, uh, I don't know what, 360 sizes. So you're purchasing a 360 crown, the bulk together, or maybe 250 crowns, 240 crowns bulk together. So you're investing so much heavily behind buying the sizes, because if you have one size means, I'm telling you guys that one size tooth only will be there in your practice today to crown on. Although if you feel that I have all the sizes available on this earth and only one size was missing, and that particular size patient is only waiting outside right now, it's going to happen. So you have to have all the sizes available. So first thing, you, whatever crown company you select, think that it should be a reduced inventory system. Reduced inventory means a least crown size fit to all of the teeth what you are treating with. So there are companies which has come up with the crown size of, let's say, 6 to 7 in total crown size, and which covers all. And there are companies which has only interiors 4 sizes or 3 sizes, which covers all of the interior sizes. That's where you can reduce your inventory, and by buying 50 odd number of crown, it's a full kit for you. So first thing is that a company which has the least sizes but still covers the maximum kind of the criteria or the shape of the tooth of your particular region. Second is how thin the crown is, because these are all this monolith crown, and guys, I'm telling you, thin is the best. If it is a bulky crown, you're going to reduce your tooth more, sorry. And in order to reduce the tooth more, the NVHS deciduous tooth is very small. If you keep reducing it, there's no fun. And when you are doing a vital tooth prep, like let's say a class 2 or anterior cervical restoration, which a composite doesn't stay often, you want to put a zirconia, which is, because of the high pulp font size, it stays on a higher level and placed well. If you prep a little more, it's going to expose to the pulp. So hydrogenically, you shouldn't, it invades into the pulp. So whatever the crown should be in a least thickness, let's say 4.4, 0.5 millimeters is a good thickness crown. Third feature, if you're looking to buy a kit, a crown should have inside retentive surface. Some of the people have grooves, some of the people have some glossy surface, which is highly not recommended. Some of the people have some sandblasted 0.25 to 50 micron surface. That's again a very good thing, because that makes the crown rough sort of from inside, so that it can stick over a tooth. Guys, because these are the crown system which are extremely passive fit crown system. It is not an active fit crown system like your SS crowns, because SS crowns has a mechanical fit and your zirconia crown has a passive fit. So everything is relied over your 3 component: your crown shape, your bulk of the luting material inside, and the bulk of the tooth available in mix. As once you get luted, makes as a monoblock and all stick together. So imagine a crown has a smooth surface, then the trying to dislodgement is harder. So if you have grooves inside, or if you have something sandblasted surface inside, is by far the best you can have. Fourth feature which I can say to before you pick up a kit is the margin. Thinnest of the margin is the best margin, because when you go subgingival, your margin is little thicker. It is quite harsh to it. It will remain as a pocket. It's not going to heal that easily, and that's where the biggest problem starts. These are the crown system. Beautifully can go subgingivally. The way it goes subgingivally, and it goes little more subgingivally beyond the limit. In SS crown, it shows simple problem is called blanching. Here there will be a little blanching, but with time, zirconia is one of the most biocompatible materials, so the blanching will get reduced and go away, and your fibers of your gingival will also get attached towards the crown margin. So that's a beautiful thing you are giving to a child. So mind, my guys, the fourth factor is the margin. The fifth and most important factor, according to me, which is highly under recognized and least talk about, is glazed versus glazed and polished versus non-glazed and only polished crown. I'm going to repeat it again. Glazed plus polished versus glazed. Sorry, I'm going to repeat again. I fumbled. Glazed plus polished versus only polished, not glazed crown. Now there are multiple literature available online. You can go to PubMed to read it. Glazing increases the opposing tooth wear. So guys, pick up a crown system which is mildly glazed or non-glazed. Because if you are buying a good quality zirconia material, a good quality zirconia, the only polishing in a monolith gives you a fantastic fill, a life-like looking restoration. So you don't have to glaze it, the crown, in order to have a more glazy looking crown. Because glazing, if you don't put the glaze, it's a only polished crown which has the least opposing tooth wear, which has been noticed. And sixth, and the most important thing is, five are the factors which is regarding shape and this and that. Sixth is regarding the material from the crown is being made for. Guys, please look into it. Do not go behind all this cheap and materials from the crown is being manufactured, because your crown shape is the least of the botherance when it goes in a child's mouth and going to stay, because many of the people, many of the companies uses industrial zirconia, and they are not food grade or they are not FDA approved zirconia to manufacture some of the crowns. So that's where the crowns maybe sound a little cheaper, but they're not that great to go in anyone's mouth. So go for the branded material. They are always good. They are research backed companies. You can see their data, like maybe let's say an Ivoclar, maybe let's say 3M Lava. They're all like research for 100-year-old companies, and plus they have data of last 10 years, 15 years with all this thing published, that what are the problems associated with this crown. So go for a good quality material of the crown. Don't just pick up any random kit. Okay, these are the 6 points majorly I've highlighted how and which company to buy for zirconia crowns. Then comes the zirconia crown. How the things going to get proceed. I've just put a little talk here so that I can move down to the cases really quickly after this. So first thing, as in SS, is your crown size determination. Now we all know that it was given in a textbook of keyword that multiple ways of selecting crown size, but they are like very tough. The most easiest way is, what I do is to check the mesiodistal width, because mesiodistal width is a standard thing. If it is SS, strip or zirconia, mesiodistal width will decide what crown size will fit to this particular tooth. Okay, so that's like the standard parameter to go on. So you can measure, once is a wax bite. So if you're doing like single tooth restoration there or multiple tooth restoration, before you prep, you can put a wax sheet there. You can use a modeling wax. You can have a biting wax, which is also very good, which is stable. It doesn't get deformed that easily. So you can use your bite wax. Ask patient to bite, take it out, and on the bite you can put your crowns in directly. Disinfect the bite obviously, and crown, and check according to the mesiodistal width. Put those crowns and do it. You can use a digital caliper directly in the mouth. Some people try to do it. They are succeeded. I don't know how far it is success. I've never tried that much because it sounds really scary, and then you have to again follow disinfection of that caliper. A lot of people does also use a periodontal probe in order to measure the crown size, because it is a graduated probe and you can measure the crown size. That's also one of the measurement of mesiodistal area. And last, some of the people are really good fan of impressioning, which I am not. I hate that step. I'm not going to do it. I'm not going to advocate that you should do it, and it's too much for that step. Okay, you make an impression, it goes in the lab, to pour it, you retrieve you check and then it works on. I highly doubt it's going to happen. It's going to happen. So my favorite is a simple trial and error method. I think Randall says it give this method. It was published almost 15 years ago. I think 2003 or 4. A trial and error method. I simply adore and follow that. Randall's trial and error. A simple method you see with your usual inspection that this is a medium sized tooth. Okay, medium sized tooth means either 4 or 5. You take out 4 or 5 from your armamentarium, check which has a perfect size, keep it aside. Put your teeth away. Whichever crown gets used, use it. The other one doesn't get used, you can disinfect it chemically or you can autoclave it and put it back in the kit. So that's my way of working. I don't waste my time taking a wax bite, this and that. Yeah. Sometimes it is a complex case like a full arch zirconia case, then I always make a bite first and then before I begin, because that's where I want to know that I'm not overboarding, because once you miss a little overpressed crown, if you put it on 7.5 or let's say 7 for here, and then by the time you are going on the other side, the space is not there because you eaten away by putting a wrong crown size by 2 to 3 millimeter each time, and here there is no space for the crown, so it gets jumbled up. So that's what I do on a wax bite pattern method, but otherwise I am always for a single or double unit or particular quadrant side is my particularly a trial and error method. That's what I follow. That's my favorite method as well.
Okay, sorry guys, something happened. I was left with the screen. Something happened, just it just came back. I don't know. Okay,
Rohan, actually, this is sometimes internet issue, but it's fine.
okay, I
I
can
think
go ahead.
everything is fine now.
Okay, you
Yes,
can
yes,
hear
please.
me also, right? Can you hear me?
Rohan, I can hear you
Perfect,
well.
perfect. Let me go on. Okay.
Yeah.
So now let's see. This was a beautiful picture. So some of the pictures you must have seen in the presentation, this clicked by me. I love this way of photography. So this was a picture I think I'd taken in Amsterdam, if I'm not wrong. Okay. Okay. It's next to a dam street. Okay. So let's see. Usual preparation technique. What I normally follow is a simple technique. I'm not a fancy person to buy some fancy armamentarium, fancy bird. I always reduce my occlusal. And many a times we don't need to reduce occlusal because if you're using a posterior, if you're talking about the posterior ones, when you do your pulp therapy, when you excavate it, it's normally mutilated. It's 1 to 1.5 millimeter, which you have to reduce from occlusal area, is always gone. But I love using a flame shaped burr, which is there in anyone's armamentarium. The reason is if it is a less mutilated tooth of some of the cusp are left, if you use a straight burr or something, you just make the cusp flat. Although it doesn't make a difference because any which ways the zirconia crown will come and it's going to cover everything. But I love doing tooth preparation. Okay, we are not as good as prosthodontists to do it, but this is our given a little chance on a little tooth to the preparation. And I love to follow the I mean tooth contours and go one cusp to another cusp and then just shape it up very well. So I love to do that, and it's just my habit of doing it. You can just make it flat also. Table flat is also good. You can follow the contour is good. You want to call follow the contour. This is a burr which you can see around a flame shaped burr which helps you to go contour to contour, and you can do it. The interiors is simple. You can some people ask that when there is a big labial region which you have excavated and somehow you could manage to save a palatal area and an incisal edge of the tooth. You'll see particularly many cases further when I'm going to show. So how to do prep on that? Simple. Because we don't have the demarcation margin and you can't use the flame shape burr, another clinical tip I can give you is take your normal straight burr. A normal straight burr when you talk is going to be always 0.9 millimeter in thickness. So you take a straight burr and at your incisal edge, you put your two depth cuts. Okay, you'll see this technique when I'm going to show you the video also later. So two depth cuts you put and then you flatten it up. So that's where you realize you cut your incisal edge 1 millimeter. You not overcut the crown and over the tooth unnecessarily because the labial portion is totally gone, palatal a little left and the incisal edge left, and this is the only strength of the crown and you don't want to jeopardize the strength of the crown. So this is another tip I can give you, and I'll show you in the video as well. So that's my occlusion reduction, 1 to 1.5 millimeters. Then comes the proximal slicing. Okay, now proximal slicing is very, very, very critical. In textbook way, we do the proximal slicing first, and then you do the labial and lingual. But I normally do labial and lingual first, and then I go the proximal, because proximal always goes subgingival at a time, and it provokes bleeding. But now at this point of time, why anything you can do, or vice versa. For me, zirconia tooth preparation is only a two-burr technique. First burr is you can start with a straight burr, as I said, or a flame shaped burr in order for the occlusion level. Then you just change your burr from the shaft and then put it in a round and taper burr. In many companies, it's TR11 or TR whatever, 71 or something. You can figure out. You should have this kind of a looking in my slide, which is looking a round and taper burr. You can go for a green, which is quite coarse. You can go for a blue band, which is enough. Black is too much for a deciduous dentition. I normally do not refer using black or red. You can stay between green or blue, which is comfortable to you. And many a thing for the interiors, I prep with a finishing bar as well. How, I will explain you later at that point as well. So you can take a crown and taper burr. And now this is the point we need to understand and we need to engrave in our brain, because we all are habitual to do so many SS crown. Many of the countries still, like in India, stainless steel crown is still an exam procedure in MDS exam. So we've learned this procedure so well, and so well we've learned is we never touch our buccal and lingual portion. So we are only habitual to do a proximal slicing a little bit so that our thin stainless steel crown can slide in and it gets mechanically interlocked. Here, everything changes. Okay, that fundament, you have to put it aside and you have to think it in a way that I'm taking a round and taper burr. Now, first, I'm going to work at equigingival level. I'm going to reduce 1 millimeter proximally each side, and then I'm going to go to the buccal and lingual or palatal area, create some depth cut grooves. I'm going to show you video later, and then flatten the whatever the grooves is taken, and then create 1 millimeter overall prep, and then go subgingival and refine the prep, because last subgingival is my last step, because that's where a lot of bleeding happens. And then if it bleeds first, you can't see your tooth well, and you may over prep or you may under prep. Why are we doing this preparation? Is any crown system available on this earth for preformed zirconia has to go subgingival 1 and has to be a passive fit 2. Now this has to go subgingival means you have to do subgingival prep, and has to be passive fit means you have to, sort of remove all the undercuts around. You have to remove all, angles. You have to, any sharp angles has to be removed and make it into round angles, and it has to go parallelly. The stainless steel ground goes one side to another side, this side to that side it goes, but zirconia ground goes parallelly. So guys, in mind, we have to prep a tooth and we have to reduce a tooth, which is not part of our pediatric dentistry DNA, which we have learned doing a lot of SS crowns, but this stage required a little bit of grinding of tooth, and we have to grind it. So on that note, I'm changing the slide. Comes your buccal and lingual. Here in the schematic diagram, basically you are reducing only the bulge portion. Anterior, mostly any crown system you take, it is going to be prep less crown, except palatal area refinement and the proximal or the cervical area refinement, you can say, and I'll explain more in the clinical side when I'm going to show you the cases. But posterior is going to be more on the buccal and lingual or palatal. That bulge of a deciduous crown, which is like this in shape, has to be reduced and make it flatter so that the crown can go slide straight in and should have a fantastic passive fit of it. Okay. And then last part is obviously subgingival, because if you do subgingival first, it's going to bleed like crazy. Pediatric gingiva is highly vascular, so it's going to, bleed easily. I'll tell you some of the tricks and turns in order to arrest the bleeding immediately and to have achieve hemostasis and do a fantastic quick luting also, immediately. And then you place the crown with your finger. It has to be completely passive. If you press the crown, and if you're putting on the undercut, if you press it more, see the crown will fracture immediately. The crown will fracture. So you can't press the crown the way you are checking with your SS crown. Just need to change the habit of doing and working about it. Now on the patient, if you do this technique, what are the constraints we face? So first thing is the cooperation of a child. So in SS crowns, when you're doing, it's almost like you just do a proximal slice and you snap the crown over. So it's the snapping is so quick. Here in zirconia, you are literally prepping the tooth, so it needs a little bit of cooperation of a child. So you have to, and you can't do the whole preparation under rubber dam as well because it is also in subgingival part. So hardly rubber dam comes to a rescue. So it has to be non-rubber dam and water coming by in aerota and this and that. So nitrous is something really useful. Anything and everything we do in our practice, like all 6 chairs of my practice are have nitrous output. So for us, it gets easier. For you, please, if you don't use, please get into it. We, I think, -2 webinars before this was the dearest friend of mine, Dr. Gupta, spoke on nitrous oxide. You can attend that. It was a fantastic webinar, and to kickstart with your nitrous practice. So cooperativeness of a child is very, very critically important. GA versus chair side does play a major role because GA gives you liberty to prep the way you want, the way you do it, and you can go swiftly. If you're using chair side, doing 3, 4, 5 counts is difficult because these are the crowns go subgingival. Also does require a lot of subgingival prep. So you need to work under anesthesia, or at least you should have a potent, what do you call a topical anesthesia so that you can do it. So that's why you have to create a demarcation. The problem is how to begin, because many a time it happens that when you're doing a full arch restoration, people get stuck. Should I prep anterior first and posterior later? Should I prep posterior first, anterior later? And what about canines? When should I prep? When should I place it? And endo versus prosthetic sequence. So when you're working under endo, so what happens is you're rehabilitating the full mouth under local anesthesia. The problem is some people love to finish all the endodontic part first, like they finish all the pulp therapies and restoration first, and then in the subsequent visit they start placing the crown, and that's where they get stuck. Some of the people feel that I should just finish what the child is allowing to finish. So if I pick up one left side today, so I'm going to open up, I'm going to clean it up, I'm going to restore it, I'm going to finish it all together in one go, and then I'm going to go further, and that's where it goes jumble up and gets. So these are the small constraints to understand when you are doing everything chair side versus GA, or what to begin, how to finish, and these are the things to look after. And how to solve this constraint, I'm going to tell you in the further part of presentation as well. Now, common pitfalls. Okay, what are the most commonly occurring problems? And I have faced the problems. Okay, these are the problems I've faced. The first is the time. Many times it happens that it takes little longer time compared to your SS crowns, because if you're not acquainted doing any prep in your life much before you are a typical pediatric dentist, you were doing more of the SS crown in your life. This is going to surely take a little more time from your compared to your SS crown practice. So pardon me guys, let me switch on the lights. Okay, so that's going to happen that you take more time. So child's cooperativeness, it can be taken as a toll. So you need to take care of your time factor. That's extremely important. Second, how to manage prep on a vital tooth. As I mentioned, sometimes once you overboard in a prep, sometimes you select a wrong crown size and you prep more unnecessarily. You are iatrogenically exposing a pulp, and then child, if you're not anesthetized the tooth, child gets into excruciating pain, and once it pains, child gets uncooperative. We all know what happens then. They just stop trusting you, and then all this stuff happens. So, and if it is an anesthesia, it doesn't pain, but you have to perform the full therapy altogether again. Excuse me. Pulp therapy all over again, and then you have to do it. Third major constraint is over prep versus under prep. If you over prep the tooth, it may happens that you go for undersized crown, and then the rest of the places gets like, let's say, imagine you're working on 8-4 and you over prep it, you go for one size smaller and you fix the crown, that's okay. But whatever the over prep of 2 millimeters will be a space loss from 2 of the teeth as well, and that will add up into malocclusion later. So that's also we are creating problem. Under prep, and then you try to fix the crown, you press the crown unnecessarily and try to achieve for the excuse me, active fit. It's going to be it's going to break the crown. So that's again another challenge. And no space for the crown. So this is what happens with me all the time. When I do 3 or 4 crowns together, let's say a lower canine to molar segment, you are restoring 8-3, 8-4, 8-5. You've luted 5, you've luted 4, and now before luting all 3, 4, 5, when you placed it to try and it was fitting fantastically well, but before luting, it was. And once you started luting it, the last tooth doesn't fit at all. There is no space for the last tooth. Why? We'll see it later in practical part. So this is something, a critical problem which I have encountered multiple times, and how to avoid it, we'll see it in the later part of the cases. So yes, let's see some of the stories. I never say when I say case, because I would always get into the story first, because as a pediatric dentist, okay, I truly believe that every child who comes to us has a story, and every family has a story. And once you get into the story and you give a successful outcome, you are part of the journey. And their journey is so fantastic, and you are part of the journey, and that creates a beautiful story for them which they remember forever. And guys, I can tell you that's a beautiful thing. It's a word of mouth in order to get multiple patients once you treat one good patient in your life, because that one patient is going to go out where you're part of the journey, where you're part of their life story, and they're going to speak that story to so many people out. You're going to get so many people patient again. So that's how the system works. So your case story is extremely important to connect with your people, and that's where you really grow to your practice. Okay, and that's how it is. So let's say this case, this was a boy came up to our practice, a typical 3-year-old boy. The parent had biggest concern was brown looking teeth. They thought, they went to a pediatrician. Okay, the child was around 3 years, some of the months old, and they went to the pediatrician considering that this was a side effect of the iron medication they were taking, because it looks like coffee dark brown stain, and they never realized that what's going on in their life. And the pediatrician also misdiagnosed it in the beginning, because it was coinciding with the factor which they were taking medication from the year 1 or 2, because child has some severe iron deficiency in the beginning birth year of their life. So they were chronically giving this iron medication to them. So pediatrician thought of this is because of iron medication. They just advise keep wiping off. Nothing's going to happen. Forget it. What happened in the future is the child started losing the tooth structure, and one particular tooth which you could see is from my side, which is visible as 5-2. I don't know if the screen is flipped on your side. It's a letter inside that I'm talking about. And once you lose that tooth, they realize that something is wrong with the teeth. Why the teeth quality is deteriorating, and my child doesn't eat anything from the front, and whatever it is, the major thing was it is not looking good, because they got their second or third birthday pictures done, and then all brown teeth on the front. They were not happy. So they went to another dentist, and they said this is not important, this teeth is going to fall, this and that. That's typical story. And they somehow found about us, and then they came to our doorstep, and they said, doc, I need to do something. You need to do something. You need to fix my child's teeth. I said, yeah, can be done. He's like, but this teeth is going to fall. Then we had a proper counseling that when this teeth is going to fall, and then what are the importance of front teeth and how it helps in the phonetics. If your child is going to start losing the structure like this, then it's going to get into lisping, and other issues going to come up. And they were like totally into it. Like, my God, we never thought of this could be the issue, but I came for the color. Okay, I did not realize this is sort of an infection. This is sort of kind of a bacteria growing in my child's mouth, which may go in the stomach and spreading everywhere. I had no idea about it. So guys, this is what I'm trying to tell you is all about the story. It's all about how you connect, how your communication from your team members is with the patient. Okay. And they got really excited. Okay. And we showed them a couple of cases, what we've done in our past. This is a pre-one, almost similar to kind of your case, so that they can relate to it. They saw the post-op, like, wow, pearly looking white teeth. They're like, no, I really want it. The mother was so fascinated. And before we finish our conversation, the first thing they ask is, when can we do it? When can we pull this thing out? I want to do it ASAP. I said, okay, let us book a good time. Okay, fix an appointment. Why don't you just come by? And this is all in the same region. So I'm going to inject one shot of LA, and I'm going to finish it all together, like my endo treatment together, because this all these needs an endodontic treatment as well. And then we're going to restore it. If the child remains cooperative on the same particular day, I'm going to fix all my 4 crowns together. And they're like, can be done in a single shot? I said, yeah, it can be done. It should be done in a single shot. And let's see what happens particularly. So child came, put them on a nitrous around, 4.5 was my level of nitrous when I was working. I particularly remember I use a different method of anesthesia. So we put a gel, we have just jet injection. So we give a little shot of LA. You normally use a thinner gauge needles and cartridges. Was anesthetized. Child was watching TV, ceiling mounted TVs we have over each chair. Put her headphones on, watching some Peppa Pig episode, and then story began. and I started excavating the teeth. So this is what I achieved after excavation. I got shocked. My God, it's like nothing here, almost subgingival. There was some sort of an abscess developed here because before they arrived, I could not notice that in the pre-operative, but they must have taken a little time once they came. I don't remember. This is a little older case. So kind of an abscess here, active infection, and I excavated from here, and this was just a little stem of a tooth left here, like pretty bizarre situation. I mean, the time was early for us, so we got into the mind like, okay, zirconia can be fixed or not. But yeah, I can tell you guys a simple fundament I truly believe in is that if you can do an endo treatment and save the tooth, you can place the crown. Forget it. If you cannot do an endo treatment, you can't do crown. That means you have to extract. But if you could manage to pull out endo treatment to be on each tooth, it can be restored with crown. There is no zirconia available which will not fit. It will fit, it will stay. Just follow the simple rule of working. Okay. So this was my palatal view. I think the picture is flipped, so the right side is left side. You can see I finished my biomac. Extremely important, guys, when you are excavating from the cervical area, please make sure you are not touching this papilla because it's a very weirdly keratinized tissue. It takes a lot of months times to heal, and it keep bleeding all the time when the patient brushes. It's a non-painful situation, but quite irritating, and parents will eat your head up if you are not taking care of this issue, and then it keep having the bleeding all the time post-operatively, and parents will eat your head up. And plus, whatever the time when you're excavating, make sure that this cervical area, right, cervical area, you are saving it so well so that the minimum bleeding means minimum time waste while you isolating the tooth in order to receive a crown, and it saves our time, it saves the energy waste. So just make sure that when you are just excavating with your air rotor or your slow speed motor or your spoon excavator, your grip has to be in a way that you are not touching marginal gingiva, or save it as much as you can. Okay. Then we did the obturation. Now this is how it looks. So guys, when in a totally mutilated tooth, the golden tip of obturation is you need to reduce the obturation 2 millimeters from the cervical area. I'm not at all a fan of post-encore, and I have not done any post-encore in my life apart from doing my post-grad exercise, which was mandatory to do it on a deciduous tooth. I did it, but after that, I've not done a single one because I work on a different principle of endodontic monoblock. What I do is I reduce my obturation up to 2 millimeter cervical line because that's where the resorption stops, and till that level only we require to put a biodegradable or bioresorbable or obturating material. I clean my chamber so well, there is no single fleck of this obturating material is there, because if you lose out a single fleck of it, that's where we're going to put our GIC, and our glass ionomer cement can adhere chemically to the tooth structure, and it has a bond over it. But what happens is the biggest problem is that if this obturating material is there, it is not going to adhere and it create a bigger trouble. So clean this chamber very well, inject that material so well here. You can try using your capsule GICs. I am a big fan of capsule GICs. I particularly in India, the 3M's name is Fortacfil. It's a light cure capsule GIC, or you can use a Ketac Universal or Ketac Molar capsules as well. Both of them sets quickly well. Fortacfil is a command set, so it sets within 5 to 7 seconds. So you can use any and inject it well, create a lump, and then you can just sculpt it in a way so that the crown will fit well. Let's see what I did it in this case. So yeah, so this is what I got it. And then I did my little bit of prep here in particular region. In this kind of mutilated dentition, I do not use any active diamond point. I only use a finishing diamond point. Those are the yellow band burrs, and that too also particularly round end taper yellow band burr. Round end taper yellow band burr, guys. You can write it down if you're listening to me. There's a go-to success burr. And this burr also helps you to revise the prep when you do for posteriors. But anterior, I solely prep with sound and burr because majorly what am I prepping is I'm just shaping my freehand or a capsule composite in order for the good parallel fit for my passive fit crown to slide in. So what prep I did just a little bit of prep here on the cervical of this lateral so that my crown can fix here on the central and here on the distal side of the lateral insides and on the right side as well from the canine area. I just prep it and sculpt it. On a labial area, I use Softflex disc. These are the discs available globally, and I know so many people. They love this disc. It is like in four shade: dark yellow, dark amber, light amber, yellow, and light yellow in shade. So that it depends on the coarseness of the disc. The darkest one is the most coarse. The lightest one is the more of polishing, finishing ones. I took a disc and I just roam it around the labial area of it, and I did it. Now, what is the question is the palatal area? Palatal area, I normally don't touch. In particular, when I'm going to show you the video just right after this case, I'm going to show you need to prep the palatal area, but I'm not a big fan of prepping the palatal area. Why? Because all the crowns, deciduous crowns, are like 0.5 mm in thickness, not even 1 millimeter. Okay, these are that thin crowns. And if at all you have a little layer over the palatal area of the tooth on the palatal side of a deciduous dentition, doesn't make a sense, because doesn't make a difference, because any which way is a space dentition. Any which ways there will be a good difference of your overbite and overjet compared to your permanent dentition. Okay, overjet is little spaced in a way that your little 5 mm which you've added up by not prepping your the deciduous tooth will not make any difference. Okay, so it's going to slide it over, it's going to stay there, it's going to stay there forever, no problems. Okay, I'm going to show you how I placed on a prepless area and how it looks. So I placed my crowns, I checked it, it was all good. I luted. Okay, and this is my post-operative after 1 week. Can you see how beautiful it looks? It merged so well. The marginal gingiva adapted on the tooth surface like fantastic. It looks like the natural tooth. My abscess was healed and everything was fantastic. Even now the canine is not looking good because the biofilm is adhered. But the zirconia, there is no adherence of biofilm. That's the biggest advantage of a zirconia crown. No biofilm is attached, so it looks fantastically well. And that's what it is. Let's see how it looks on a palatal area. That was my pre-op, that's my post-op, and that's a fantastic palatal area. And I have not prepped my palatal, but can you see a little bulge here? Maybe, but it doesn't look like more bulge, so it is not going to hinder. And even in the palatal area, it has adapted so well that it doesn't require to do a preparation on the palatal area. So normally I do not advocate using any burr or any system on a palatal area. Let it be the way it is. The prep the proximals, go subgingival, prep the proximals, prep the labials, slide the crown on, done. For anteriors, I highly recommend, guys, you can write down, this is another tip, because I must have tried 20 different companies and 20 different type of luting cements. Nothing is work. Only thing is work is Rely X U200. Rely X U200. That's a 3M's pure resin adhesive. I truly recommend. You can use any other company's pure resin adhesive. Kerr also has it. GC also has it. You can use it. I use particularly this brand. That's why I'm talking about it. Why pure resin? Biggest advantage of pure resin, number one, is it says quickest. Okay, quickest. If you have to do 4 crowns together, you have to put your zone in, isolate the whole areas, take your 4 clicks out. Why I like that U200, it comes in a clicker. 1 click is equal to 1 anterior tooth. So you put the click, take the click out, mix it all well, load it all the front 4 crowns together, isolate the areas, slide it all 4 crowns together, put your finger as a pressure, take your light, take your each tooth, 3 seconds. Okay, 3 seconds, not more than that. Now this tech cure doesn't see, light doesn't pass to zirconia. You are not curing anything inside because it's a dual cure cement, but it helps to cure the cement at the cervical area. That is where the major bleeding and the seepage is happening. So you want to prevent that. So you want to cure the cervical area very well, and the cured cervical area has an excess material also hanging there. So you can just click it off the excess material with your any spoon excavator or a DG16 or any other probe or any instrument which you are very comfortable with, and take a floss and floss it out that easily. So it's so quick. Imagine now you're not using a pure resin cement. Imagine you're using a GIC, a pure chemically to be set GIC. What's the initial setting time of GIC? Any brand, average 4 to 5 minutes. So what's going to happen? You mix it. Mixing time is 2 to 3 minutes. You load the crown. You put it on the child's teeth like this, and you have to keep hanging on with the thumb, because these are the passive fit sounds. A child moves, done something on the tooth, try to check it or fiddle it, crown gets, tilted, comes down, and it's going to stick like that. So you're going to keep finger pressure on for minimum to minimum 5 minutes. Maybe it's going to take more time, depends on the atmosphere and temperature and many reasons. So I don't know. So that is why I truly recommend using pure resin cement only for anteriors. I'm not saying for posteriors, okay? Only for anteriors. And the third and the most biggest advantage, I would say the biggest advantage of using the resin cement is resin pushes the blood away. I'm repeating, guys. Resin pushes the blood away. What's going to happen? There will be some cervical bleeding because you have prepped it subgingivally, cervically. You've tried to, put those hemostatic gel. I personally use, there is called a 3M's astringent retraction paste. 3M's astringent retraction paste. Basically, this retraction paste is like a compule which is invented for opening up the margin. If you don't want to use a cord, it opens the margin and opens the margin for your impression material to go, and you can make a good subgingival impression. But why I use it? Because it has an astringent in it, and it's like a clay form. So when I put it on, it just required 90 seconds. You can flush your water with your high vac, 3-way syringe. You just flush your water, some spray. It's like a clay. It will dissolve, and your margins are little open because you will have a comfort zone of the crown to slide in. One, and two, it blocks the bleeding. It blocks the bleeding. So it's not hindering, the bleeding is not hindering your luting material to get adhere with your tooth structure. And resin pushes the blood away. So if at all there is a bleeding, once you put that crown in, it pushes the blood away aside. Immediately you put a light, cervically it get cured. Wow, amazing. The problem gets solved like this, you can see. So these are some of the practical tips, guys. Write it down. It's going to help you once you do it in the future for sure. That's my 6 months post-operative. How cervical it is fitted very well. The child was doing very well. It came for a routine fluoride visit. So we had a checkup. We took an X-ray. Child went home, pretty happy. Wow, extremely good. So before I begin with another case, I'm going to go and do the start of the screen sharing and going to show you, okay, a video of my tooth preparation, what I normally was talking about. So it's a quick video over the model which you can see it, and which will also give a little rest to my throat. Guys, if you cannot see the video, please tell me. I mean, please write it down here. एक second. आ गया. Okay. So, okay. Is my video visible behind?
वीडियो नहीं चल रहा अभी, आपको अपनी स्क्रीन शेयर करनी पड़ेगी.
All right.
But you are visible. You are there.
Okay.
Yes, now you can. Now it's
visible, right? So let's see how it goes. So you've selected a crown size. On the other tooth, I've done my strip crown demo on the same one. So you've selected the crown size. Again, it works on the same principle of mesiodistal width. You can use the round burr or this kind of a burr if you're comfortable with. I normally do it with my straight burr if I have to reduce the anterior the incisal edge. So I create a little depth cut like this, okay, and this is a depth cut of a burr which is 0.9 millimeters. So eventually, once you refine it, becomes 1 millimeter. I'm going to scroll it a little faster so that you can understand what I'm saying here. Is then you reduce your with the depth cut area so that it is 1 millimeter. Incisal edge is being reduced. Now this is on a tooth which was non-endodontically treated, so it has a full this thing. Now, if at all, if you have to prep a label area, it's a very rare case scenario that you have to prep a anterior area. Okay, a very rare case scenario. So you can also make a depth cut there. And depth cut, I would always show like this, that you reduce one side to another side, one side to mesial, one side to leave the distal, and leave the middle portion there, because that middle portion, the stem which is hanging in the middle, will tell you how much you are prepping. You are not over reducing it or not. And then finally, you can reduce the middle part as well. This is very rare for the anterior step, because 90% of the cavities which we treat in the anterior region is going to be labial, because we treat maximum of our kids in ECC, and that's the origin or that originate, and that the main surface involves is the radial. Okay, so this step is 90% is going to get omitted. Now this is the step which I was showing, which I normally avoid. I don't do it, but depends on you. So on the cingulum, again giving two depth cut grooves, and from the cingulum I'm just pressing it towards one of the mesial side and one of the distal side, and then slowly and gradually I've reduced my cingulum of 1 millimeter overall, and make the prep flush and clean from that particular area of proximal, moving down to the proximal, and then merge it. The final step of this would be doing my subgingival prep, and then going subgingival, refining all the margins, and doing it. So now guys, imagine I've just took my zirconia crown in my hand once while the doing crown size determination, then I've put it aside. I am not touching my crown at all. Doing everything what I do is on the tooth. It's not your SS crown, you keep modifying it. And now once you do the prep, you press the crown, you check the fit, everything is perfect, you are happy, load the crown with luting, press it on, cure it, it's done. It's that quick and simple, the way we saw the case. Okay, so coming back to the cases, guys, I think I'm going to stop the screen sharing and going towards my slides. And I think the slides are visible. Yeah. Guys, can you tell me if my slides are visible? Okay, okay. I think wasn't visible. So, okay. Sorry. Perfect, perfect. I'm back. Yeah, yeah. Got it, sir. Thank you.
Fine, fine. Okay.
Fine. Okay. So another case, this guy's name was Abir Maheshwari. We treated almost this case around 4-5 years ago. We have a Mumbai clinic, as sir mentioned before. So one of our pediatric dentists saw this case in Mumbai, that some of the dentists tried to treat him there. They were not happy. Father works in another pharma company as almost a CEO level. So he found out child was under tremendous pain everywhere. Some of the GICs been filled. Some of the area was temporary was filled. Child was under tremendous pain because all these filled areas had some of the pulpal inflammation, infection. So they were under extreme pain. I met them. Abir at that point of time, I think 3.5 years plus. So the city which I'm talking is like almost 700 kilometers away, 500 miles away from my area where I practice. So we decided that they will fly down to my place where our major center is. That's where we treat kids under anesthesia as well. So this was the case. We treat them under anesthesia because I wanted to finish everything in one go so that they can travel back the next day to the hometown, and they can resume, the father can resume to work as well. So this guy's name was Abir. Abir was 3.5. He was our poster boy. He's a very cute looking boy. I think in my presentation, I have his full picture as well, which you can see it. So beautiful looking kid, was under pain, tried multiple doctors, tried some hanky-panky things, and that hanky-panky things did not work out anymore because there was no legitimate things tried on it. So we took the child in anesthesia. Some of the areas we did the labial opening, some of the areas where the decay was on a lingual area, so we had to do weirdly, but yeah, we had to do palatal openings, canines we've excavated. This is my posterior. So imagine, guys, we just removed GIC, and that was the amount of pulpar hyperemia, and the soft decay was there. And then no wonder why the child was under constant pain, not able to eat, falling sick multiple times. I've put up this video of the testimonial of the parents, I think a year or 2 ago, on our Facebook channel. You can check it out. And I'll tell you the story later. Okay, so I'm not killing the cat now. When we excavated well. We did my biomac, we cleaned it up very well. Lower tooth, both the teeth we excavated, biomac. This did not expose to pulp, the 7.4. So we decided to go for a restoration, both 8.75, exposed to pulp, we did it. So we finished our obturation. I did my Ketak molar restoration. I did my GIC, filled up everywhere, just did it very quickly, haphazardly, because it has no value. Eventually, you're going to tooth prep the tooth, and eventually it's going to cover with the crown as well. So then we started with our tooth preparation. This is what I'm showing anterior first in the slide, but you can see it behind. I finished with the posterior first. So if you do a multi-arch restoration, I'm going to show you two or more the cases later where I'm putting almost 18, 18 and 19 zirconias together. So my key to success mantra is start prepping for posteriors, then come down to anteriors. Don't prep anterior first and go to posteriors, because somehow it doesn't work. I don't know why, but somehow it doesn't work. So, but in a slide, I'm going from anterior to posterior so that it looks good. So anteriors, after restoring, you could see I did not prep much. Softflex polishing here, a little bit of burr here, a little bit of burr here. I've somehow bruised the gingiva. That was my mistake, but I'm still showing it. Doesn't matter, because it was a cut made by, maybe my handpiece got moved. I could manage to get that cut very bad. Yeah. So then I checked my crowns. This was like 2 in size. So I fitted. It was fitting very well. Why? I checked it with my canine guidance. So here, sometimes canine plays a major load in order to check the whole arch. Here, my mesobuccal of each 4 number tooth, and then comes the canine, and then it should touch it should match the arch shape of your incisal edge as well. So that's how we did it. These are my posteriors. We fixed the posteriors. Lower posteriors also we fixed it on a particular day. Somehow we checked the occlusion within anesthesia. It's very tough to put the tongue back and check it, but we wanted to check the occlusion, that we should have a fairly good occlusion. A little, let's say a marginal gap of 0.5 or 1 millimeter of high point will work, because we work with a lot of flexible condyles. So there is no so-called practical high point in any pediatric dentition, I can tell you guys. But don't leave the mouth open. Okay, that's crime. But here you can see it, a fantastic occlusion we achieved that particular day. We discharged the patient. I could not find a 1 week picture, but child came every 6 month visit. This is, I'm showing, skipping the steps. 1 week, 1 year picture. You see after 1 year how fantastic it was. You see the marginal gingiva, how beautiful it is, how it is attached. Even parent forgot that which one is a natural tooth and which one is the zirconia crown. They were extremely happy. These were my posteriors. You can see the beautiful margins, how it is hanging on almost a year. These are my posterior teeth. That's my occlusion after a year. A fantastic occlusion in this shape. It hardly visible that which one is an original tooth or which one is a zirconia crown. Beautiful. Incredible smile. That's my OPG of post-op. Fantastic. Must be a child around 4.5 years of the age. After another 2 years, child came for the follow-up. We asked him to pose. That time the child was around 5.5. So before the start teeth shedding off, he was sitting on our chair, and on my mobile I just clicked this picture. A fantastic smile. You can't even make out. He's having, if I'm not sure, but let's say 4, and 10 zirconia in his mouth. Okay, 10 zirconia in his mouth. You just can't see it. Look at the broad smile. Fantastic. This was a poster boy. He loves coming here. Now, every time he comes, makes a visit every 6 months. He spend minimum 1 hour playing to a play area, posing it well, because it's like a dental home for him, because he's been coming since he was a little one. So that was a positive attitude for us, right? So, why I'm not having another slide? Sir, are you there?
Son, I'm there.
Yeah, so why am I not having a slide? Why can't I? My slides have stopped because there are many slides after this. I can't see the next button.
Wait, just wait.
Okay. So sorry for the glitch. I could not see my whole presentation.
Is this?
Oh, that's okay. It's got splitted up on one. Yeah, particle.
Yeah, I told you it was difficult for me to upload 140 MB. So I divided it into parts, part 2.
Okay, I have a lot of high resolution pictures. That's why it must got heavier. Sorry,
Yeah.
But thank you so much for helping out. Okay. So, okay, this is a fantastic case. I love this girl. Okay, I love this girl. I'm going to go back. Okay, sorry. The girl's name was Rumesha. The father was a physician. Okay, he's an MD physician. I don't know somehow how they missed it. It was almost a full mouth decay case. Anterior, all 10 of them got decayed. Okay, posteriors, almost all of them got decayed. Okay, and miserable decayed, all like deep into the pulp. Same complaints, child was under pain. That time child was around 3. Crazy stuff. Okay, so we started excavating. That was the interior. You can see all the label area was gone in order to create an access opening. We prevented the cervical area so that it should not bleed that much and bother us. Okay, posteriors we excavated. Lower posteriors we excavated. This too is not exposed to pulp, but quite a lot mutilation. You can see. Okay, then we finish the case. I'm going to skip some of the slides because it's going to be repetitive, and I'm already all 1 hour plus time. So, okay, this was my post-op. You see, beautiful smile. Even the canine were restored well. The upper full arch, okay, except this tooth, everything else was zirconia. Lower full arch was almost for zirconia, except one tooth which we could not. We could manage to perform the pulp therapy, and it was almost like a root sum. We advise parent to extract a lower incisor, which is the least value in the whole mouth. But parents said, okay, we're saving all the teeth. We don't want to extract, so we somehow saved the tooth and we left it back. So that's the OPG of the whole patient. You see upper 9 and lower 9 teeth hanging. The same protocol I followed. I started with posterior preparation. I started preparing posterior. I came towards the canine. I stopped. I came towards the canine. I stopped. I came towards the canine. I stopped. Came towards the canine. I stopped. Then take one quadrant at a time. Then I took one quadrant at a time. I selected my crown size. I revised my margins if required. Then I isolated it. Now posterior luting is only Ketaxam. That means Ketaxam means it's a 3M cement, so that is pure GIC I use. That's why you don't need to, if you don't need to use any resin or resin modified cement doesn't require, no need to spend money there. Posteriors is good enough because that's where you place the pressure. It's a big crown, it's a big chunk of material, so it stays there. It adheres. I have got never trouble or dislodgement or crown comes out later or that day. Trouble with the pure GIC cement. So posteriors with pure GIC, place, finish one quadrant, go to another, finish one quadrant, go to another, finish one quadrant, go to another, finish one quadrant. Now you're left with canine to incisor segment. Take a break, breathe well, again go back to the system, because that's where you have to create the whole arch into the system so that it should have a proper arch. The teeth should not be placed furthermore or further back, or you should not spoil the whole occlusion, because here we are not doing any FMR, doing those fancy articulators or face bow transfer, etc. It's all more arbitrary, more judgmental thing. So take a break, guys. Then comes your anteriors. Still don't prep canines. Canines are your guidance, okay? Canines are last to be touched. Then go for your central incisor, lateral incisor, prep the teeth, adjust the teeth, put it there, leave it. Now, leave your lateral incisor in. You've already luted your 4, that is your first molar there, that is luted. Your lateral incisor is not luted but adjusted. So put it on, put your thumb there, and now you got canine there, and then you prep the canine. At this point of time, you have to be diligently careful that you are not grinding the zirconia crown. If your bud touches a zirconia, it's a rough surface. That's where the plaque colonize, and it's going to be a bad biofilm eventually later. But why am I asking you to leave the crown in? Because that's where you're making a judgment in order to grind the tooth, because it's a middle tooth from this side to this side. Okay, from posterior to anterior, it's a middle tooth. So somehow you may have occupied, or sometime when you lute it, crown fits in a little diverse dimension and it occupies a millimeter or more. And if you've done an ideal 1 millimeter preparation of that canine, your canine tooth will not fit. So that's where we have to make sure. What do we do? A prep of more. So canine will take more jolt of prepping more. And why we can rely on canine more and taking that kind of a giving that kind of a jolt to canine? Because canine is a stronger tooth with a stronger root, and which is got a good bulge as well. You don't want to prep your incisors more because it's so fragile. You don't want to prep your molars more because it is very important to chew. Canine is particularly hanging there to cut, and for the aesthetics, let it grind more, let it take the fall. Okay, so you prep the canine more. If there is no space, if there's good space, prep canine to 1 millimeter. Take out your lateral, put your lateral, let your lateral be there, put your canine, check it is fitting well, very well. Take out everything, isolate it, arrest the bleeding, and lute. Now luting protocol, when you're luting canine with 4 incisors differs. canine and four incisors differs. When you're using only four incisors, you lute four together. I explained in the last case. But here, when you're luting canine as well, then when you're taking the canine, then canine and lateral you will lute together each side, canine and lateral you will lute together each side, and then you will lute the anterior, because it will give your time more. Because if you can't lute six together, it is practically impossible. You take out 6 click of any material, I mean any company's pure resin, you mix it, you load it, and you put it on. That time is too much. It's going to set. And if the material sets in the tooth, I mean, sorry, material set in the crown, that crown is wasted. You have to sit and dig out and take out the material. It's extremely tough and it takes time. So you need to take out another crown from the armamentarium. And if there's only one size and one crown in your armamentarium, guys, you are dead. So guys, be patient. Canine and lateral first, canine and lateral first, and two of the centrals later. That's how it's going to follow. Okay. On that note, let's say another post-operative of the same OPG 1.5 years later. And this is the beautiful pictures, a canine to canine, molar to molar smile, incredibly beautiful result. Okay, gingiva is beautiful and pink in color. Child was extremely happy, eating, drinking, everything, gain weight. Parents were happy, lower incisor, fantastic results, brushing well, no problem. That's an occlusion which we have got it. Beautiful. Okay, that's my OPG again after 1.5 years. And now it is due. It was the last year, December. So they were supposed to come this May, but they could not because of this. This is a girl. We clicked the picture in last December when she came. You can see the beautiful smile, what she has it, what she's wearing it. She's wearing a fantastic pink dress, but more than that, the smile she's wearing is more fantastic. So this is what we are powered to give. It's just not those aesthetic dentists gives incredible laminate smile to people and they get really happy. It's not. We also have a power of giving this kind of beautiful smile to kids so that they can laugh and live their life until the teeth falls off. That's in our power and that's in our hand, and that's what we want to perform. Okay, on that note, I'm going to show you one more case, and this could be the last case of the presentation so that I can take some question answer as well. This kid name was Ivan. He was a Christian boy, came to our practice. It was a 3 year, I mean, quarter to 3 year almost, or preschooler, typical preschooler boy, came to our practice. Father was very, very well to do. It's kind of in our particular city, they owns clubs and all, etc., like big supermarkets and all. He had this kind of brown stains, according to them, since the time he's got birth. So it's not time of the birth, but the teeth must be arriving. And child was chronically bottle fed. He was an IVF kid. Mother didn't get that kind of a feed. That was a little history, I can tell you. And child was chronically bottle fed from day one, on formula particularly. So that must be the cause of the ECC. They've shown it to their pediatrician. Pediatrician says, no way, there's nothing, there's a trouble. There was an asymptomatic at that point of time. And even when we treated, till that time, this kid was asymptomatic. The previous one I shown you was a symptomatic one. This was totally asymptomatic, but there is a different story with this. So this kid, one day, he came home, he was grumpy, unhappy, and he didn't play, didn't eat well, and slept. Next morning, he woke up. Parent wanted him to go to a preschool where he goes to, very nearby. In India, preschools are normally, it's kind of household phenomena that a good small house, they construct a bungalow or a villa, they construct as a preschool, a 2-story preschool where kids can play outside and have kind of inside and kind of a daycare system, which you see it in America particularly well. So that's where he was supposed to, parents wanted to drop him off. And kid was not ready to go. And he made a reason that he's having a tummy ache today, so he doesn't want to go to school. Parents like, okay, he was grumpy yesterday, there must be a tummy ache today. Let's not push him. He's a preschool, doesn't matter. Let him skip a day or two. He didn't go for a day or two. Third day, then parents said, okay, why don't you go get ready? We have to go to drop you to the school. He made another reason that he's having another problem today. So it went by like 5-10 days, and then parents realized that this is something fishy. Every morning he's all right, and the moment we say that he has to go to school, he cries, he fights, he remains grumpy for many hours, and he refuses to go to school. Almost a 3-year-old child. What is going on? Okay, what's wrong with this? So parent decided to go to the school and find out what's going on. And then they went to teacher. Okay, he was not ready to get in the car the moment the school name came. They went to teachers to ask. Teacher, like, they had no idea. No one has hit him. There was no fight or something. Okay, no teachers have touched him, or or no child has hit him, or you went to indulge into any kind of a kid fight. But teacher said, okay, let me inquire what happened. And then teacher took 2 or 3 days and they inquired. They start asking each kid and then started getting on a friendlier note. And one kid eventually said that they read some story in a storybook that rat ate a kid's tooth and kids becomes a monster and kind of teeth. And then it started smelling and this and that. Some kid's story, maybe must have watching the TV. Some kids said the story or they read it somewhere. And that's time immediately the other manifests this story. That story boy is this Ivan, and they started teasing him and they started bullying him. This, you are the boy, now your teeth stings, we don't want to play with you. They stopped sharing toys, books and everything. They didn't allow them to touch when he comes to nearby. And those kid thing, what happened, they made a cluster and he was just left aside. So it happened for a day or two, and then Ivan decided, I'm not going to school. Now imagine a 3-year-old boy is now having a low self-esteem. Okay, that's the word I'm going to use. It very, very difficult and complex word, but I'm saying low self-esteem, not happy with his smile, and not happy with the condition. The house, the family is disturbed because child is not happy. Okay, because kid is center of attraction of any parent's life. So they're not happy. The whole thing is like everyone is tossed. Father stopped going to office because he's not happy. Father wants to buy him toys and all. He's still not happy. They went to a dentist. One of the dentists said this teeth doesn't need a treatment. You give this medication, it's going to all right. They give them some antibiotics. Parent took it for 3 days, gave it for 2 to 3 days. It did not work out very well. Again, the point is, child is not happy. Okay, the end of the day, child is not happy. Every morning, he see his teeth. He wasn't happy. So what's the solution? So somehow they found out about us and they came to us. It's like, doc, I don't care whatever happens. I want this child to look white teeth boy. Okay, this is what these fathers were, a white teeth boy. I don't care what happens, but whatever you treat here, it should be a white teeth boy. I said, we can do it. Okay, we can do it. For me, it's like an hour job. He's like, no ways it's possible. I say, yeah, I can fix it. He's a fairly cooperative kid. We'll put him in a nitrous. And he's going to keep watching something on the top. We'll do all single visit and we'll get rid of it. He's like, really, you can do it? Really, it can be done? I said, yeah, why not? And I don't remember, it was must be a Thursday or something like this of the end of the week we were getting into. And that's where they made their appointment. They came. Let's see what was the situation, how we treated him. So let's see the pre-operative. This was the pre-operative, right? The majorly the front four teeth were involved. That's a palatal view. Uh, we did our cleaning and disinfection, exit openings we performed. So that's the area, there's a structure we were left with. You could see somehow I excavated. I'm not a fan of leaving caries behind. Somehow I can't just do it. I'm a bad judge of anything in my life. I am a least judgmental guy. So I don't judge a tooth with an affected or infected caries. Either I excavate or I leave. There are only two things. Okay. If the child is uncooperative and there's a good time to go for GA and asymptomatic tooth and the COVID kind of time going on, I'm going to apply SDF and send them off, arrest it. Or when I'm going to treat them, I'm going to treat them all. Okay. Give them a beautiful smile. I'm not a guy who's fancy to leave something on and then do it, and it's so unpredictable. It may cause pain again. What are you going to answer to the parents? So I'm not that guy. So I've excavated all. Uh, try to save the papilla. Don't touch the papilla. Is again the golden rule. That's my palatal view. We've disinfected it well. They were ready to obturate. I did obturated this. So that's a beautiful. That's my. You could see on the label area. There's so LA mark. So we gave a 2 shot. A small 1 ml of LA was good enough to pull out this much. Okay, because the child was already in the nitrous, so there was not much of the. It helps for the relieving of the anxiety as well. So that's my post endo restoration. Again, the key to success is clean it, guys, from the cervical area very well. Many a time it happens. I'm repeating again. Many a time it happens that you may take more time compared to your excess opening, biomac, irrigate, obturate. You may take this totaling, you may take more time to clean the chamber compared to this time. If you've taken like 5 minutes or 10 minutes to treat a tooth, it may take 5 minutes to clean one tooth because of one fleck of a little residue of that cement. It will stop adherence of your GIC, and that's where the whole monoblock, the concept I explained, is going to fail. So make sure you be patient and you clean it really well. Okay. Then comes my post endo restoration. This was my post endo. Now, guys, you can make out the simple thing to do. And why am I showing this case? Two reasons. One is kid also does demand aesthetics. That was my one of the thing to show you this case. And second is a little haphazard way of the tooth structure which is left. So on a lateral incisors on a left side, which is totally gone, is like way below to the original level. Okay, centrals are totally there because it was not affected. The incisor edge is there, and lateral is like partially there or not, and it's like wavy thing. So this is a tricky thing to get. Now, what's going to happen if you don't prep well? This lateral 5-2 is going to go way down. Okay, way down, and it's going to be up and down situation. So you have to try to merge it in order to create a beautiful. So let's see my prep how I did it. Okay, so that's my prep. So I shape up this. I reduce almost 2 millimeters of incisor edge here on the central incisors, and 1 millimeter of the little uneven shape of my 5-2 of the right side lateral incisors. And all of them I did it with the depth cut, and then I did it. The label preparation, I did it with my FO burr, and rest of the finishing, I did it with my Softflex disc. I did not again touch the palatal area. It's up to you guys. You want to prepare. I did a little bit of refinement on the cervical area as well. But the way this crown works is going to slide it over, so there is no problem. I did my trine. That was my trine. I was fairly happy. The lateral was placed little diverse, but it's okay because that's how the tooth structure was left with, which I could not help on. So it was just like that. Okay, and then we luted. This is post-operative 1 week. You see fantastic, amazing adaptation. That was pre-op. That's my post-op. Let's see the palatal area. Even it's a non-prep crown. There is not much of the bulge. You can see it. Beautiful. Okay, beautiful. That's the occlusion. And guys, what is the end part of it? As I said, they must have booked an appointment on Thursday or Friday or something. When we finished, the next morning, child woke up. Once we finished, he went home. He must have checked himself in the mirror like 25 times how good he's looking. Eventually, what he did was he woke up in the morning. He was wearing his pajamas and he was ready with his school bag, not taking shower. Wearing those old clothes of household clothes, and he was excited to go to school. He was pushing their parents that whatever happens, I want to go to school. No ways, I want to go to school. They said, okay, today is Saturday, schools are not working. He did not believe it. For him, any day is Saturday or Sunday or Monday. He wanted to go because he wanted to show off this beautiful teeth to his friends who bullied him, and he put them aside. He did not agree to it, and parents eventually put him into the car. Took him to the preschool. They showed it from outside of the car window that the school is not open yet. You can see if no kid is there, no one is playing, no noise out coming around. And then the child believed, child ate an ice cream on the way back home just to, enjoy the happiness. And that was it. That's the thing with this static dentistry we can restore. Look at his beautiful smile. This was immediate post-op we've taken just to check how is looking good. Okay, so this was the thing. Multiple cases like this, I'm going to avoid a little bit of it now. Okay. Same ways, posteriors, full mouth ECC. Same principle followed, canine restored, full. This is the upper full arch which we have restored. Amazing results. Lower full arch. That was the primary occlusion. We didn't get the proper one on the right side, but on the eventually after a year when the patient came, we checked the occlusion. It was fairly occluded. So there was no problem. Parents were really happy. That kid was really happy. So the similar case. So I hope in this presentation I could manage to show that what are the common mistakes, what are the protocol which we follow, what is the order which we follow, what are the go-to burr, what are the go-to materials you should have, what are the normally common mistakes you made. Even I made some of the mistakes. I've bruised some gingiva which you saw, it got healed. Some of them got little prepped aside, some crown was little tilted, but on a child's mouth, because these are like 4 millimeter restoration which you are providing, eventually everything gets settled down. So I think I've made a good justice to this almost 1 hour, 30 minutes plus time I've taken. I just want to just give you a little tour before I end of our practice, which is our major center, which is back there in Ahmedabad, Gujarat, India. That's the entry of our place. We have almost 5,000 square feet place. That's a reception. That's where you enter. Now this looks totally changed because of the COVID protocol. We've changed everything. We've changed the play area section. This is how each operatory looks, which is a ceiling mounted TV, which is an output of laughing gas. So we can put it the nitrous on, and we have 4 trolleys roaming between 6 chairs. So every kid can be treated that way. It goes this, yeah. So that's the middle part of another quick quick chat room, or you can say counseling area. Uh, those are our operatories. We have a centerline nitrous, which is very common abroad, which now getting common in India as well. That's our activity area, we call it. In activity area, we've not put any screens because we wanted kids to get engaged into the age specific activity, which we have put it here. So they come out, they ask the age specific activity, and we give them one activity to do. And in order to get involved, once they finish the activity, we reward them with something. So that's how it works. We got this motion sensor and this thing, nanolift light. So it looks like a party zone to them. They enjoy once they move. The light gets. That's our sterilization room. We have proper sink cleaning system and autoclaving. That's mine. That's where I'm sitting right now. That's our consultation room. That's a lounge for the patient or some of the doctors to, if they come, they can sit and enjoy their times here. So that's how it looks in the lightning time. And I work with good heavy load of music. I love music. So I've got a good music going on. Kids, they put the headphones on, the music doesn't bother them. But music is for life. So that's the way I practice and remain mentally stress-free there back then. That's our OPG. I forgot to show the OPG which we have it. And this is the quote which I have written 4 years ago, and I truly believe in this quote because, sir, I totally agree in a principle of nothing can accomplish in life without hustle, struggle, perseverance, and a pinch of luck. I am highly optimistic guy. I am a guy who believes in luck. I am a guy who believes in faith. I'm a guy who believes in hope, in which all of amongst us who need it now in these difficult times of our mankind. And sir, I'm just sitting with my father the other day, and he gave me a definition of luck. So we were just talking like this guy got lucky, that guy lucky. He's like, no, there's nothing called luck. Luck means hard work meets preparation, and you are so prepared. And how can you get prepared? Because once you are so prepared, that means you work hard. So and any hard work can beat any talent. So guys, forget about talent. Just keep working hard. Keep getting lucky. Be there. Do it all, do it now. And on that note, thank you so much, guys, for patient hearing. Thank you so much for the opportunity, sir. Over to you, I think, and we can take questions later.
Yes, Rohan, thank you so much. First of all, it was a wonderful presentation. I must tell you, your presentation was 2 hours and 2 minutes.
My God.
Yeah, not that 1 hour. Okay, I'll switch off the slides first, and then we will take up the questions. Because actually, what happened? I don't know what happened on in between. I lost all the questions. That's the reason I have requested our attendees to post it again. Because nothing was visible in the chat, but now I can see few of the questions. But I was just looking at the number of people who have joined us today. So in between, it went to 393 also, and we have roughly 29 countries.
My God.
Because I know personally from about 28. And one more was there. She was from Africa also. Right. So we have from Costa Rica, India, Bangladesh, UK, Dubai, Quito, Ecuador, Italy, Dubai, Libya, Colombia, Egypt, again UAE, Abu Dhabi, Saudi Arabia, then again Egypt, then Sudan, then Israel, and so many, and from India, Sri Lanka, and from China and Malaysia. So this is all,
excellent.
Yeah, maybe
so anyone wants to stay in touch with me. I'm extremely active on Instagram. On Facebook, I'm not much active. Facebook is just a page. So you can find Dr. Rohan Bhatt there and just send a request. You can DM me anything, any cases. I post a lot of cases. We are extremely active, sir. We post each day at least minimum 2 to 3 cases on our story and on our page. They're like good thing, good stuff. We put it on, so quite interactive it there. So kindly follow me on Instagram. I'm very much available. If you have any questions, you can shoot up there also. And there are questions here we will answer now. And if you
And,
find it later, you can
yeah,
shoot up there.
and Rohan, we have one very active attendee from Dr. Claudia. She is
Okay.
from actually Costa Rica, which you use for your.
Okay, so I follow. It's a fantastic question, and for pulse therapy, we need to do a big long session again. But I'm just going to quickly tell you my protocol of working is very simple. If there is a case which has a periapical infection, I always obturate with any material which contains calcium hydroxide. My personal favorite is Calciplast 1 by Circamed or Vitapex. Both of them contain same calcium hydroxide, iodoform, and silicone oil. You inject it, you do it. So calcium hydroxide helps to reduce the periapical inflammation and it heals faster. But the only problem with any calcium hydroxide based material is it resolves very quick. So if you put this obturation, sir, you will agree with this, and you speak a lot of things on endo. If you put this thing in a 3-year-old child's canal, and after 5 years or 3 years, you make an X-ray, the canal looks empty. So, but that area is sterile, so not a problem. But normally in a normal day, I really love ZOE because it absorb. I mean, it resorbs with the rate of root, and it's economical also, damn economical. And you can use your lentular spiral as a centrifugal force to inject it. So, but on a non-symptomatic tooth, I would prefer ZOE in order to find it. And on a symptomatic tooth, I would go for any calcium hydroxide based material, particularly Vitapex or Calciplast 1 by Circamed.
Okay, Rohan, there is a quick question from Rupal. She is from Mathura, and
Okay.
KD Mathura. She's asking you about zirconia crowns. Can we give in posterior teeth and the GA?
Zirconia crowns can be done under posterior teeth.
I mean, zirconia in posterior teeth can be done under GA.
Absolutely. You saw my two of the cases I done under GA, and GA or LA doesn't matter. You can put any crown. The only question is about occlusion. And I saw another question in the chat about occlusion is we work on a dynamic dentition, right? We have a flat curve of P and we have the developing mandible, which is quite flexible. The condyles are quite flexible. So it doesn't have that much problem in order to have a little high point if you come out with. And even in SS, right? Imagine the Nora Hall, right? The Hall technique has so much of the height which is more, but still the technique is worldwide popularized. So how come the Hall technique is popularized? And if you can do a crown on the GA which has a 1 or 2 degree or 2 millimeter high point, so it will not create a trouble. I'm sure it won't create a trouble.
And Rohan, there is another question. I'll just read it. Dr. Dina Rabia has given one question. I think I'm missing that question. And one question is how to sterilize, how to disinfect the crowns.
Okay. So disinfect, I personally use glutaraldehyde. I immerse the crowns into glutaraldehyde solution for 15 minutes. It's the same protocol which we use to disinfect our impression materials. You can same way disinfect the crown. There is no change. In the Skinner Phillips books, there are 5 different solutions they've given with a tabulated form. I'm not put it up here, but you can find it in the book. You can use a hypochlorite as well. You can use a glutaraldehyde as well. You can use ethanol-based solution as well. You can use some of the commercially available Septodonts rapid solutions as well. Corsolex rapid also. But average time is 15 to 20 minutes or 10 minutes you have to immerse in. Take it out, put it back. People have tried doing autoclaving also. So if you can clean it into your biosonic machine, that's ultrasonic, and then you can autoclave it. They have reported that up to 6 cycles of autoclave, it doesn't deteriorate the just shade of the crown because this is polished zirconia. But after 5 or 6 autoclaving cycle, it gets more darker. So if you this crowns are A2 B2 shade, so that adapts to the human population very easily. So it gets little darker and goes to the A 2.5 or something. So, but I normally disinfect it with the solution. That's a chemical one I follow.
And we have a question from Dr. Arham Chauhan. He is a brother like to me. He's from Pakistan, basically.
Okay.
You know, since he has not given his question before, so I could not know whether he's online or there because I could only see the people who have given the questions here. And
Okay.
then he messaged me on my WhatsApp, Virender, you forgot me. And Ram sir, we cannot forget you. You are very well part of me personally. So I cannot forget you. Only thing is, I could not see your name since you have not posted any question. So sir is from Pakistan. So we have few delegates from Pakistan also.
Wow, lovely.
And his recommendation, his question is: do you recommend about crown lengthening when there is too less tooth structure?
It's a very good question actually, and I did like in a previous time, sir. It was a very because a big dilemma, and if someone is a practitioner like he is, he can understand. Then you take your laser and you do crown prep. I mean crown lengthening. You take a cautery or let's say a scalpel is going to bleed a lot. You can't put a crown with a laser NDX 2.5 watt, more than enough. You can do your crown lengthening and place it, and then gingival gingival fibers will grow and will adapt. It happens, but then I somehow some days I thought of, okay, let's save the time, and I did not do the crown lending. I used to fix my crown normally, the cases the way you see, and it came out with the equally good result. Then I stopped doing my crown pack. Like same thing I told you with the post and core, right? I don't do post and core. Just inject your GIC very well, create a lump, slide your zirconia down. Zirconia goes 1 to 1.5 millimeters subgingivally. You have your good adhesive cement. It's going to stay as a bulk, and it's not going to create a trouble. I have shown you a follow-up of almost 4 years. It doesn't make sense of doing extra labor of work. But yeah, excellent question. I used to do it myself, then I stopped doing it. So that's why I really like the question.
And Rohan, there is a quick question from Dr. Mutaz Hassan. He is from Sudan. Dr. Isra is also there from Sudan with us today. How to deal with the high crowns and the crowns which develop periapical pathology?
Okay, after treating, post-op.
Yes, like it's a high crown. The crown was not into occlusion; it was left high. Or once you have given a crown and the pathology develops, how to go ahead with the root canal treatment and all that. This was the question which was asked by
Okay.
Dr. Monica also. She's from Abu Dhabi.
Okay, excellent. So I've treated many times. So I'm be a human. I have no shame admitting that some of the times that I've treated pulpectomies and it has failed. It has got another level of periapical infection after maybe sometime 6 months to a year. On that particular day, when you make an X-ray, it's been fantastically done obturation, and periapical things were relieved and everything, and no symptoms. But somehow after 6 months or a year, person gets the pathology again. It happens like 1 in a million case or 1 in 2 cases in a year or something. And that's where you have a zirconia crown there. What are you going to do? Two things. Either you can pull out the crown, or you can drill through the zirconia crown and you do it. Never try to pull out the crown. Even SS, even zirconia. If you try to pull out the crown, 99% of the time you will pull out the tooth only. I'm telling you, you will pull out the tooth only. Never try to do the crown. Now you feel that you want to clean up the margin and you do it. You want to remove the old crown, then you can cut the crown. And the way you remove your SS crown in the pieces, give one tooth cut and then remove in the pieces, you can remove it and refine it and then put the crown again. Or you can drill through the crown and you can do it. Both the things, to cut the crown and drill through the crown, there are good. Trihawk is a good global company birds available, which is a zirconia cutting burr, which is little different. It is golden in color and very brutal burr, very hard burr. Normally don't required to cut a tooth kind of it. It's the next level of diamond points you can use to drill through the tooth. You can go down, create an excess, clean it up. Now, what going to do it with the occlusion? Now, occlusion is the least affected area. So, sir, what I would advocate is that area should be restored with your composite and get it merged with your zirconia crown. So that's how you can save the crown and you can retreat the tooth again. Or if you want to remove it, cut it and remove. Never pull out the crown. You will extract the tooth for sure.
There is one more question from Dr. Harshita. She is doing post graduation in Ahmedabad Dental College. Does these zirconia crowns stain?
No, it hardly. So if you eat a lot of turmeric, so I've got kids who had haldi doodh, that's what we call in India, the turmeric milk. There are a lot of countries who believe, I think a lot of Egyptians also drink, and they will agree here, the turmeric, they take it as a therapeutic milk. So that stains a little, but ideally the habit has to be brush at night. So I don't think so the crown gets stained. Zirconia never gets stained. It's only some of the dark pigments they eat and they don't clean it well. it looks stained, but it doesn't stay longer.
Okay. There is one question from Dr. Hiral Shah. She's a postgraduate in D.Y. Patil Dental College. And I'll club one more question by Dr. Shalu. No, one more question. I forgot the name. How do we check for the occlusion for a zirconia crown in case of full mouth rehabilitation under GA?
Very tough. No, it's not possible, sir. Only thing works is your judgment. Full mouth rehabilitation is a very complex word in pediatric dentistry. I've tried to find out to say something is called full mouth is how many number of teeth are involved, then you can say full mouth. So I've got a lot of cases on Instagram where I was saying that 20 of them we've replaced, 18 of them we replaced, and sometimes 10 of them we replaced, and still we term as a full mouth. So full mouth is a very complex term. Let's say any case, I'm going to divide in two segments. This question is one case scenario is when there are more than teeth which is canine also involved, and when there are more than teeth where canines are not involved, because canine is a cornerstone. Like in adult practice, which I've never done it, but that's when all my friends say is they work on the canine guided occlusion. We don't have a canine guided occlusion concept here, but canine also tell us easily that where you are. So if you are working on a posterior on a GA, you can take a demarcation that this is what it is, you can be. And the best demarcation is any good company crowns if you buy. Any good companies crown if you buy. And those crown only go 1 to 1.5 millimeters subgingivally. That's the ideal height of your tooth. If your crown goes more down subgingivally, that means you over prep the crown that day, tooth that day. And if it is showing us margin lesser, that means you under prep it. So crown height of the zirconia is one demarcation. Second, canine guidance is a second. And that's why I said when the complex cases, now scenario number 2 is canine also involved and you're going to do the full arch. Then you do your posterior first, leave your canine, do not prep it, finish your anterior, don't lute your posteriors, don't lute your anterior, put your lateral there, your luted 4 is there, that's your first molar, prep your canine, fit your canine if it's fitting well, take it out, lute your anteriors, and last is to go is your canine. So that's how it's going to work. So it's a little tricky, but if you do 1 or 2 cases like this with this protocol, it will follow.
In few words, you will answer, Rohan. Sanjana wants to ask, she's a postgraduate from People Dental College, Bhopal. What is the best impression material and which type of cord is used for some gingival placement? Single
I don't advocate.
or twisted one?
I don't advocate. Worst impressioning is worst. Okay. But if at all you want to do it in kids, I only use a silicone. If at all I want to make a space maintainer or an ortho appliances, it's a silicone. And cord packing, I've never done it, sir. I'm admitting it truly. I've never done it, so I'm the worst person to answer. If you at all you want to use it, I use the 3M's astringent paste for the contact openings and hemostasis. I use that, but I'm a bad answer to say about cord packing.
Okay. Rohan, one more question. What is the ideal height of the prepared tooth in case of zirconia?
As I said, sir, ideal height of a prepared
wants to ask this question.
Yeah. So if you get a single cusp with you on a posterior, that's the best way to create as a template and reduce only that cusp to 2 millimeters. That's the height. Let it be other side is slanting and other side is open. You reduce that 1 to 1.5 millimeter. When your crown goes, it's going to be fit sale. If you've lost the whole occlusal structure, then you're not going to prep at all. Rest of the area, when the crown goes in, will be occupied by your luting material. And that's how the system of monolith, monolith preformed zirconia crown is going to occupy the whole space. So, no worries.
Okay. Rohan, my postgraduate Burhan wants to ask you, in case of a quadrant dentistry, which one affects the occlusion the most, zirconia or stainless steel crown? Which affects the most? In a quadrant dentistry, yes.
Which affects the opposing dentition more? Which wears more?
No, otherwise occlusion, like which is more sensitive for establishing occlusion, zirconia or a stainless steel crown?
Zirconia, definitely. Zirconia, why, sir? I'll tell you. Because if you are in a postgrad, again, in India, we are so much used to, pediatric dentists are so much used to doing SS crowns. We are not habitual to grind the tooth that much. That's where our conscious bites when you are grinding the buccal and lingual. So once you do like your 100 and 200 preps, now then both of them gets equal in the beginning phase, right? Because zirconia came later into our life. Like you and I both learn SS and work SS on a primary stage of our life. The people who are into adult practice, they grind the teeth more. So when they do it, it gets easier for them. So that's the kind of answer I can give you here. It's like mix thing, you know.
We have, okay, Rohan, which material we used for making build-up, post-endodontic build-up in case of this?
Excellent question. I said I love using light cure glass ionomer cement. That's my go-to material. I only use capsules. If you are using GC, every country is called GC2 LC or Equia Forte. If you are using 3M, it's for Tac Field of 3M. These are the two companies I advocate using any GIC material. Post endo is critical step, more important than endo. I'm not saying I'm taking away the credit of endo treatment, critical step in terms of criticality, because that's the most neglected step in a good way to say it. But that's where it's like, okay, it's just need to fill up. No, you need to fill up that well, clear the chamber, and create that bulge area so that avoids a post-in core that can give you a surface for the crown to stay on. And light cure GIC gives you liberty to cure it that point of time so that you can do it cordon dentistry quickly. If you're using powder liquid GIC and you mix it and put it there, it takes 24 hours of final setting time. Until that, you cannot prep the GIC. It's like, otherwise hot knife in a butter. So that's why I use light cure GIC. That's my go-to material.
Okay, I think we are done with all the answered questions, most of the questions, and most of the questions you have already answered during your presentation. Uh, Dr. Supreet wants to know that which company crown you recommend. I am sure Rohan will recommend only signature crowns.
No, 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 no. I'll tell you. I'll tell you. I will recommend two of the companies I equally love. Not that because I am greatly involved with this company called Signature Crowns, and which is 3M material we use. But I still really like Easy Pedo Crowns. If someone are from America or South American people, they get Easy Pedo Crowns really well. I love those crowns. I'm telling you, that crowns are very good and equally good, I would say, and maybe more than it. So I'm going to be biased to answer, but someone wants to buy a kit and signature is not available for them, go for Easy Pedo. It's little expensive, but amazing crown system, good grooves, good fits, longevity excellent. The shade never fades. I've got 5-year-old Easy Pedo in my practice as well, and fantastic crown selection. They have a narrow size as well. Inventory is not as large as other companies. I don't want to criticize other companies, but other size inventory goes up to 14 sizes. These guys made beautiful crowns. So Easy Pedo is also a very good company.
Okay, Ron, I think we have already crossed 2 hours and 33 minutes.
My God.
We were supposed to be live for 1 hour. I got message from one of my friends. He said we have a time limit for our webinar. So what I always say, knowledge has no time limit. Knowledge has no time limit. Like we can distribute knowledge, we can share knowledge, we can learn as long as we want to. So it was wonderful, Rohan, having you here. And I always look forward to see you again and again on this platform and share your knowledge, expertise, experience to all our people. And students really liked this webinar a lot. They really learned a lot because my phone was ringing with so many messages, right? So still now you can see on the backdrop, it's still tingling. So you got so many regards and wishes and compliments.
Thank you so much.
India and abroad. Thank you so much for this wonderful effort for compiling all your cases for us and sharing all your clinical cases, Rohan. Thank you so much.
Excellent opportunity. Thank you so much. Thank you for being there. And I'm sorry if I could not address any of the questions. If you still have it, keep buzzing there. As I said, you can Instagram me on my DM. I will answer each of the questions. I never miss out on anything. But thank you. On that, before we end it, sir, I would like to say thank you so much to you. And remembering the day we met, it made me so nostalgic in the beginning. But all kudos to you. Always been there for me. And I appreciate all the efforts you put behind in my career to shape. Thank you so much.
Thank you, Rohan. Thank you so much. And I thank all the attendees for being with us for so long. and it's a 2 hours and 35 minutes. Maybe few people must have, started their webinar platform earlier also. So again, Dr. Stenja, she's writing in Spanish, but now I can little bit understand what she wants to say.
My God.
Big thank to you, and thank you so much, Dr. Stenja, for everything, for supporting us. All attendees, please stay safe, enjoy your stay at home, and be healthy. Keep connected, and I have already shared my number with all of you. If anything is needed, I am always there. And any question you have, I can always get you back. I can ask Rohan anytime and get you back with the answer. Thank you so much. Thanks a lot.
Awesome.
Bye bye. Take care.
Thank
And
you. Thank
see
you. Thank you.
tomorrow with one more lecture that is by Dr. Mukul Jain. He will be talking about SDF. So same
Perfect.
time, I will see you tomorrow. Bye bye.
Sure.
Take
Thank you.
care.
Thank you so much.
Have a pleasant evening. Bye.
Yeah.
Bye.